I'm Dr. Steve Harris. I'd like to welcome you to your Pharmacology Kaplan Review. To tell you a little bit about myself, I currently serve as the Associate Dean for Academic Affairs at the Pikeville College School of Osteopathic Medicine. I'm an Associate Professor of Pharmacology. I have a PhD in Pharmacology and Toxicology from the University of Georgia. I have a research background that includes breast cancer research. That also includes a 3-year postdoc that I did at the National Cancer Institute in Bethesda, Maryland. The work there included work on tumor angiogenesis and novel anti-cancer therapies to inhibit the development of blood vessels in various types of cancers. I began teaching pharmacology about 14 years ago, and the last 11 of those has been in Pikeville at the Osteopathic Medical School. I began working for Kaplan Medical about 8 years ago and have had the opportunity to travel and teach in a variety of locations for Step 1 reviews. We're going to begin our review with general principles. Our first section and our first chapter is going to be on pharmacokinetics. This will give us an opportunity to look at our first slide here, which has a variety of things, and I'm going to bring these up one at a time. The first deals with drug administration, and you of course know that there are a variety of ways to give drugs. Most often that's oral. There's several advantages to the oral route. That includes the fact that it's safe, it's convenient, and it's usually less expensive than the other routes. But there are many ways that we can give drugs. Drugs get absorbed into the plasma. That allows the drug to move into the blood and then ultimately to be distributed to various tissues. It can be bound up in the plasma to various plasma proteins, or the drug can even bind up in various tissue storage sites as well. Of course, we hope that the drug will interact with its receptor, and that will relate to its mechanism, and we'll talk about that. Many drugs are metabolized. Of course, the liver is the primary organ for drug metabolism, but certainly it's not the only organ. Lung, liver is the primary one, but lung and other organs contribute to that. And drugs are excreted, the kidney being the primary organ there, but again, not the only one. You have biliary routes. The lungs are important in that case, and in some cases, sweating is a way to eliminate drugs. If you think about this, we're really talking about two very important terms here. The terms are pharmacokinetics and pharmacodynamics. And these terms are interrelated, and I would imagine that these terms will kind of take you back to your early days in pharmacology when you first reviewed these basic principles. I like to illustrate these by using some simple definitions. And my simple definition for pharmacokinetics is what the body does to the drug. Really, it refers to the actions of the body on the drug. And in some ways, you can think about pharmacodynamics as being the opposite of that. Pharmacodynamics really involves what the drug does to the body, the drug's action on the body. And it's not hard for you to imagine that what the body does to the drug will influence what the drug does to the body. Let's take a look at our diagram now as a whole, and let's talk about which parts of this actually represent pharmacokinetics. Well, the drug can be absorbed, the drug can be distributed, the drug can be metabolized, and the drug can be excreted. And those are all various ways that the body is doing something to the drug. So that represents our pharmacokinetics portion. Pharmacodynamics, on the other hand, really involves this box right here. That involves the interaction of a drug with its receptor. So very importantly for your Step 1 exam, that involves the mechanism of action of drugs. And this is going to be more important really for you on Step 1 than on the other steps, where they test mechanism of action very heavily. But there's another component to pharmacodynamics in this particular part of our diagram that's also important for your exam, and this is side effects of drugs. Many of those side effects are mediated just simply by overstimulating that receptor. And of course, side effects are going to be tested not only on Step 1, but also on the other steps. We're going to start with some basic principles here, and the first principle we're going to look at is drug permeation. And permeation, of course, refers to the ability of a drug to move within the body. There are several factors that influence drug permeation, and you see those listed on the slide. I'm going to highlight two of those for you here. Lipid solubility is a very important factor for drug movement in the body. In fact, the ability to diffuse really relates to that particular property. So many drugs are designed to be lipid soluble. The second property here is concentration gradient. Of course, the movement of drugs in the body is very much influenced down its concentration gradient. Most drugs are going to move passively in the body. We will talk about the concept of ionization very shortly, but the fact is that only the free or the unionized form of the drug can contribute to that concentration gradient. Now, surface area and vascularity are also important, but a little lesser so than the first two factors we've just talked about. When it comes to surface area, how about an example? The example here would be stomach versus small intestine, and I'm thinking now about drug absorption. If you had to predict the absorption of a drug just simply based on surface area, you could easily tell that drugs are more likely to be absorbed in the small intestine, just simply based off of the larger surface area with all the microvilli found in the small intestine. Vascularity is also an important factor simply because it is going to influence the movement of the drug. The more vascular the tissue, the greater the movement of that particular drug. And you might think of an example related to routes of administration. For example, if you were to inject a drug intramuscular and compare that to injecting that same drug subcutaneously into the fat, you know that muscles are a more vascular tissue, and so the chances are that the drug is going to be absorbed much faster by the intramuscular route. And you might take a segue here to a situation such as shock, where you've got reduced blood flow, and that's going to influence the movement of the drug in the body. And it certainly would probably influence the way that you administered a drug, and of course in shock most drugs are administered intravenously. Our next point is going to be related to drug ionization. And first thing you have to ask yourself is this an important point? Is this something that I really need to know? And I'll just give you a tip here that most drugs have groups that can be ionized. And this is probably around 80 to 85% of all drugs have this particular property that they can be ionized. So when you think about ionization, it clearly applies to most of our drugs. The concept basically says this, that most drugs are either weak acids or weak bases. And those weak acids or weak bases can exist in one of two forms, and I'm going to highlight those for you here. They're going to exist in either the non-ionized form, and you need to think about non-ionized as being non-charged or uncharged. Compare that to the ionized form, of course, which would be the charged form of the drug. Now, predicting how much drug is going to appear in either of those forms, you need to know the pH of the environment and the drug's pKa. So let's highlight both of those as well. The pH of the environment, you should be able to predict certain pHs, and I will give those to you as an example coming up very shortly. And then also when you think about drug pKa's, most often if the exam is going to want you to do anything with the concept of pKa, they're going to tell you the pKa of the drug. You just must use that knowledge to answer the question. And of course, by definition, the pKa is the pH at which the molecule is 50% ionized and 50% non-ionized. Again, to hit this point one more time, only the non-ionized form can cross membranes. In other words, charged molecules don't penetrate lipid bilayers very effectively. Now, it turns out that the ionized form is better excreted because it's more water soluble, and we're going to really take that concept and apply it because that could really be an important application on your exam. So in a nutshell, for weak acids and weak bases, the ionized is water soluble, the non-ionized form is lipid soluble. When we illustrate the concept of ionization, we really have to think about the relationship that exists between the non-ionized form and the ionized form of weak acids and weak bases. So I would really encourage studying and learning and memorizing really these relationships that are shown here. In fact, when you think about weak acids, there are a number of very important weak acid drugs in the body. I'm not going to list all of them certainly, but I'm going to give you a short list of some very important weak acid drugs. And if we start this list off here with one of your favorites, aspirin, that one is probably the easiest one to remember, right? What's the other name for aspirin? That would be acetyl salicylic acid. Pretty easy to remember that aspirin is a weak acid drug. But notice that some very important antibiotics, penicillins and cephalosporins, are also weak acids. Some very important diuretics like loops and thiazides are also weak acids. Now, each of these particular drugs and the fact that they're weak acids, we will cover these points later on in our notes, and we will refer to the fact that they're weak acids related to some potential drug interaction or some other property that would be useful for you. So this would be a good list of drugs to know that are weak acids. So when we look at a weak acid, you have to think about it in terms of a carboxyl group. If you like the chemistry, notice on the left side of the picture here, you've got a carboxyl group with a hydrogen attached to it. Notice that that form of the drug has no charge. That would be the non-ionized form of the drug. Therefore, that form can effectively and easily cross membranes. But if you take the hydrogen off of the drug, if you deprotonate the drug, you take that carboxyl group and you give it a negative charge. This would be the ionized form of the drug. The ionized form cannot move very effectively in the body, and therefore it is better cleared. When it comes to the weak base, again, there's also a list of important weak bases to know, and I'm going to give you some of those. Again, just a few examples to keep in mind. For example, morphine is a weak base. All of the local anesthetics are weak bases, all of the canes, if you think about those guys. And that's a very important point related to their mechanism of action, something that you will cover later on in the CNS section. How about amphetamines and PCP? And you may be thinking potential drugs of abuse here. The fact that they're weak bases may actually allow you to predict a strategy to help eliminate those types of drugs. So when it comes to the weak base, notice that on the left side of the figure here, you've got an amine group that has a positive charge, the RNH3 plus form of the drug. Of course, that's the ionized form, so it does not move very easily in the body, and in fact it's better cleared because it's more water soluble. On the right side of the picture, you've got the RNH2, which is the amine group with no charge. It's been deprotonated, so this is the non-ionized form of the drug, a form that can easily move within the body and easily cross membranes. And if you're not a big fan of chemistry, let me show you a kind of a shorthand way of remembering this. You can basically take the carboxyl group and turn it into A for acid, so that the non-ionized form of the acid is the HA form. Okay? If you take the hydrogen off of the drug, it's in the A- form. Again, it's just a shorthand way to write the same point out. If you're a big fan of chemistry, then go ahead and write out your carboxyl groups. When it comes to weak bases, again, B for base instead of the amine group, but once again a hydrogen is attached to the drug, and that gives it a positive charge. So the BH plus form, the ionized form on the left, the B form on the right, which is the non-ionized form of the drug. Again, when you think about this, the left side of our picture here is what's going to happen in an acidic environment. When you take one of these drugs, either a weak acid or a weak base, and put it into an acidic environment where you have lots of hydrogens, you're going to attach those hydrogens to the drug, whether it be an acid or a base. But if you move those drugs into an environment that is less acidic, you're going to be more likely to remove the hydrogens from the drug. And obviously for an acid, that makes it ionized, and for a base, that makes it non-ionized. So spend some time on this picture until you know those relationships. Now what this diagram will allow us to do is to apply the things that we know. What's scary about this picture, if there's such a thing, is that it's our first graph, and some of you may have a fear of graphs, and I would encourage you, if that's the case, to spend some time looking at your axes. Now what worries you first of all about the x-axis here is that you have an x-axis with a calculation on it, right? pH minus pKa. But think about that calculation for a minute. If you know the pH of the environment, and you know the drug's pKa, and you do this calculation, and you come up with a negative number, what does that really mean? What does that tell you if pH minus pKa is a negative number? Well, that means you're going to fall on the left side of this graph, and that means obviously that pH is lower than pKa, and we would define that as an acidic environment. What if you did this calculation and you got a positive number? Clearly that means that the pH is greater than the pKa, and we would define that as a basic environment. Okay? So essentially what we've done now is we've divided our graph into two parts, an acidic side on the left and a basic side on the right. Now the first y-axis that we're looking at, the percent non-ionized form. If we follow this curve here for the weak acid, I would encourage you to label the forms of the drug that are going to exist in these different environments. So for a weak acid, it's going to be the carboxyl group with a hydrogen attached to it. The so-called HA form is going to be at the top of this curve. Because if you take an acid drug and put it into an acid environment, you're going to protonate that drug. You're going to attach a hydrogen to it. And that drug is going to be highly non-ionized. And what does that mean? That means the drug is going to easily move within the body. Okay? Now, as you follow the curve, you're going to move eventually to the weak acid form where the hydrogen has been removed. That would be the COO minus form of the drug. Now, if you think about this, what is really changing as we go from this form of the drug to this form? Is it the drug's pKa or is it the pH of the environment? And you should be saying it's the pH. Because if you look at your x-axis one more time, what is changing as you move left to right is that you're increasing the pH. And if you want a visual analogy of this, imagine a drug moving from the stomach towards the small intestine. And this is exactly what happens as the pH goes up. You're going to see that acid drug convert to an ionized form. You'll notice that we cross a midpoint here. You'll cross a midpoint where pH minus pKa gives us 0. Okay? If you do that calculation and you get 0, clearly the pH is equal to the pKa. And in that case, 50% of the drug is non-ionized and 50% of the drug is ionized. You can also do the same thing with the weak base. If you start on the left side here, label the form of the weak base that exists in this particular environment. The form that's going to exist there, the NH3 plus form, or the BH plus if you'd prefer. Notice that you're still going to attach the hydrogen in an acidic environment, and that's going to be the ionized form. So on the y-axis here on the left, the percent non-ionized is very, very low. Again, if we increase the pH, we're going to move to a form that looks like this, the NH2, which is the non-ionized form of the drug. Of course, this form can very easily move within the body because it's highly non-ionized. Then we've got the concept of renal clearance as the second y-axis that we want to deal with here. And when it comes to renal clearance, the rule is basically this, that we more readily eliminate ionized form of the drug. So if you think about a weak acid, you want to think about what type of environment you want to put it in to eliminate it. If you want to eliminate a weak acid, you want to put that weak acid into a basic environment. Why? Because that makes the drug ionized. Okay? If you want to eliminate a weak base, you want to put the weak base obviously in an acidic environment. That makes the drug highly ionized and more easily cleared. So notice the arrow going down means the forms at the bottom of our graph are more easily cleared. So to summarize, if you want to absorb a drug, you want to put the drug in its like environment. For example, weak acid drugs like acidic environments to move easily and be absorbed. Same thing for a weak base. If you want to eliminate drugs, put them in their opposite environment. Put a weak acid in a basic environment, put a weak base in an acidic environment in order to eliminate them. To give you an example of how the exam might ask you a question related to ionization, you need to understand some normal body pHs first. I would imagine that most of you know these and are pretty comfortable with them. We know the stomach is very acidic, small intestine maybe slightly acidic depending on where you are, the blood 7.4, and the urine has a range usually of about 5 to 8. If you know those normal body pHs, you can make some predictions as far as what's going to happen to a drug. I will also encourage you to think about any ionization question that deals with pH and pKa by envisioning your pH scale on a 0 to 14 basis. Okay? Except this time, instead of using 7 as your classic divider for what's acidic and what's basic, we're going to use the drug's pKa as our divider. And the question is always going to tell you pKa. For example, what if it says the drug has a pKa of 5? What you want to do in that case is you want to draw yourself a line representing 5 on your pH scale. In essence, what that does is it divides the graph into two parts, which I'll indicate like this. You've got a part to the left side of the drug's pKa, and obviously a much bigger part here on the right side with a variety of pHs there. Now, what is this environment called, where you've got a pH lower than the drug's pKa? You should call that an acidic environment. And on the right-hand side, where the pH is above the pKa, that of course is going to be a basic environment. If you can do that, you've gone a long way towards being able to answer a question related to ionization. Of course, the next thing that you have to do is to envision the forms of the drug that are going to exist. Let's say that this drug in this example is a weak acid. What form is going to exist on the left side of this picture? And of course, you should say it's the HA form, or the COOH form of the drug. Of course, that is the non-ionized form. And on the right side, if you take that weak acid drug and put it into a basic environment, the proton is going to come off, and you're going to be left with the A- form as the predominant form in the right side of this picture. What if this happened to be a weak base? Just for example, on the left side of our picture, you know that's going to be the BH plus form of the drug. If you then move that drug into a more of a basic environment, the hydrogen comes off, and there you've got the non-ionized B form of the drug. Okay? Again, this will help you answer these types of questions. And let me just give you a couple of samples here. For example, if you had a drug that was a weak acid and it had a pKa of 5, is that drug going to be more effectively absorbed in the stomach or the small intestine? Well, you should recognize that in the stomach, which is on the left side of our picture here, very acidic, this is going to be the predominant form of the weak acid. That form easily moves and will easily be absorbed. Okay? If you put that weak acid drug in the small intestine, which is going to be a little higher on our pH scale, it's more likely that this will be the major form of the drug, and that form won't easily cross membranes and be absorbed. Of course, if you wanted to eliminate that weak acid, it's pretty clear that you want to increase the pH to put the drug more in the ionized form. So again, you can use this particular diagram as a sample for any question that you get related to ionization. Draw this out, or at least visualize this as you're trying to answer that question. Next, we're going to review what ionization does to renal clearance. A couple of rules for you on this is that only the free unbound drug is filtered. Remember that we don't filter drugs bound to plasma protein, certainly not normally. However, if there's a point that's very, very important here, and I would argue one that students tend to forget, it's this point right here, that both the ionized and the non-ionized forms are filtered. Okay? We somehow tend to think that only the non-ionized form can be filtered, but notice that both forms can be filtered at the glomerulus. However, it's only the non-ionized form that can undergo active secretion and reabsorption. Okay? Why? Think about that. That's because those processes involve moving across membranes. Therefore, we refer to the ionized form of the drug as being trapped or stuck in the filtrate. The other 2 points here I'm going to blow up on this slide because they're very, very important for you on your exam, because this relates to eliminating drugs and possible strategies in a drug overdose situation. So, when would you want to acidify the urine? And of course, you should be saying if someone overdosed on a weak base. And if you want to use an example of some drugs that we've already reviewed now, the clinical vignette here would be amphetamines and PCP. If someone overdosed on amphetamines or PCP, what's a strategy you could use to enhance their elimination? And of course, the answer there is to acidify the urine. While there are several things you could use to acidify the urine, if you'll look in your clinical correlate there, it says to change urinary pH. If you want to acidify, I would encourage you to highlight ammonium chloride. Okay? Ammonium chloride can be considered really a non-specific antidote for weak base overdose. Okay? Certainly it's not the only thing that you could use, but that would be a good drug to know, a good chemical to know that is going to acidify the urine. And then the same thing when you think about alkalinization of the urine. That would be the case if you overdosed on a weak acid. And what's a popular weak acid? Mainly because it comes in such large quantities and you can get it so conveniently, you might think about aspirin. Okay? Someone overdoses on aspirin, you need to ask yourself, is there a specific antidote for aspirin? And the answer to that is no. There's no specific antidote. It's one of those things that distinguishes aspirin from acetaminophen, for example, which does have a specific antidote, you might remember, in acetylcysteine. But for aspirin, we don't have such a thing. So what you might remember is that this drug is a weak acid. And the strategy that you're going to use there is to alkalinize the urine. And if you go to your clinical correlate again, there I would highlight sodium bicarbonate. Okay? Sodium bicarbonate, very effective at alkalinizing the urine, which is going to facilitate the elimination of weak acids. One more time, why? Because you're raising the pH. If you raise the pH of the urine, you're going to put aspirin into the ionized form, and you're more readily going to eliminate it. Now, you'll also notice that to alkalinize the urine, classically or historically, acetazolamide has been used. And just to give you some information, remind you about that drug. Of course, that's a drug that's going to inhibit the enzyme carbonic anhydrase. And when you inhibit that enzyme, you're going to dramatically reduce the absorption of bicarbonate in the urine. All that bicarbonate in the urine is going to serve to raise urine pH. A clinical vignette related to this concept is one on hepatic encephalopathy. When you think about hepatic encephalopathy, you might think about severe liver disease. You might think about the impaired function that goes along with that. You might think about increased production of ammonia in hepatic encephalopathy, and you can use the drug lactulose in hepatic encephalopathy. And what's going to happen is that lactulose is going to be converted to lactic acid by gut bacteria. And essentially what's going to happen is that's going to result in trapping of the ammonia that's being produced. And the process is shown here, that ultimately lactulose is going to trap ammonia in the form of ammonium. And in that process, you're going to dramatically decrease the circulating levels of ammonia in the body and thereby be of benefit in hepatic encephalopathy. So it's a related vignette because you're talking also in this case about converting ammonia to ammonium. You're acidifying in order to detoxify, in this case, ammonia production. If you like visuals, this is a great diagram showing you renal clearance of a drug. And you start here with filtration at the glomerulus. Remember that it's only the free drug that gets filtered. Okay? Unbound to plasma protein, because drugs bound to plasma protein are too large to get filtered here. Notice this, that both the ionized and the non-ionized form of the drug get filtered. Okay? Both can get in, but the difference is once they get inside. The ionized form, of course, is trapped. It cannot cross membranes effectively, so in essence, it is likely to be excreted. The non-ionized form, however, is able to cross membranes, so it is the form that's going to undergo the processes of secretion and reabsorption. Okay, so very important visual there for you. Remember, both forms can get filtered. Kind of a summary of what the glomerulus is like is that it's a good size filter, but it's a poor charge filter. Again, to remind you about the size, right, the fact that the drugs bound to plasma proteins don't get filtered, but a poor charge filter because both ionized and non-ionized forms can be filtered. When it comes to drug transport, again, this is kind of a reminder of transport mechanisms you probably have reviewed in physiology. There are three basic mechanisms: passive diffusion, facilitated diffusion, and active transport. And this applies for drugs as well, that each of these mechanisms can be utilized by drugs. But really, it's passive diffusion that is most often used. Remember, drugs move down their concentration gradient. They don't require energy, they don't require a carrier, and since there's no carrier involved, the system here is not saturable. Okay? There are only a few examples of drugs moving by facilitated diffusion. Remember, this is where the drug moves down its gradient, does not require energy, but it does require a carrier. And since it requires a carrier, the system can be saturable. Also, only a few examples of drugs moving by active transport, and one example of that we'll refer to later on in our notes, is the tubular secretion of penicillins and also of diuretics. Simply the ability of those drugs to be secreted for example, in the proximal tubule, which is where this is taking place. Since it's active transport, it's against the concentration gradient. It does require energy. Okay? It does utilize a carrier, and that system is definitely saturable. I'm going to do a little tie-in here, which shows you that any system which utilizes a carrier, of course, is saturable. Okay? Systems that utilize a carrier can be saturated, so facilitated diffusion and active transport. Okay, next we're going to look at drug absorption. Really, this is the first part of pharmacokinetics, the first of the 4 parts that we're going to cover. Of course, drug absorption concerns the processes of entry of a drug into the systemic circulation from its site of administration. Of course, movement into the blood is going to involve various factors such as drug permeation, lipid solubility, for example, a concentration gradient, exactly those points that we've covered so far. Now notice this, intravascular administration, IV, does not involve absorption. There is no loss of drug, and we'll talk about bioavailability, but for now, you should remember that the bioavailability of an IV administered drug is 100%. Okay? Importantly, does not involve absorption. There's kind of a trick question out there that basically asks you this. It says, what is the fastest route of absorption? And if you read this too quickly, you automatically fall for the trap and you pick IV. But not if you remember that IV does not involve absorption. What is the fastest route of absorption? That, of course, would be inhalation. Drugs move very rapidly into the lungs, into the alveoli, into the capillaries, in large surface area there, very rapid route. But importantly, when you think about the concept of absorption, it involves moving from its site of administration into the blood. Okay? And in the case of IV, you're actually injecting the drug directly into the bloodstream, so there is no movement from one compartment into another like there is, for example, with inhalation. Lots of ways to give drugs. So besides IV, lots of extravascular routes. And of course, if you give a drug extravascular, there is a great chance that less than 100% of your dose will reach the systemic circulation. And the term that we use here is bioavailability. Okay? If you interpret that term, basically it tells you how much of the drug is biologically available, or maybe another way to think about that is how much of your dose gets into the blood. Okay? How much of a given dose of drug actually gets into the blood, and that is the bioavailability of the drug. And sometimes that is a high number, sometimes it's a very low number, and that really will depend on how you decide to administer that drug in the future. Let's look at this particular curve. It'll allow us to set up some other concepts here. Plasma concentration versus time. When you think about this particular graph, there are a few terms here like lag time and onset of activity and duration that you need to be comfortable with. First thing is, when you look at the shape of this curve, can you recognize that this curve must be showing you some extravascular route? How do you know it's extravascular? Well, there's a couple of hints here. First of all, you're basically starting down here at a plasma level of 0, and you're increasing over time. In other words, the process of absorption is going on. The fact that absorption is going on means it's not IV. So it must be an extravascular route that's shown here. So let's start here. Basically at time 0, when you administer a drug, and you can imagine taking a drug orally. You take the drug orally, it's going to go down into your stomach, it's going to sit there for a certain period of time before any of those drug molecules actually move into the plasma. That's what we call the lag time. It's the time from first administration to when the first molecules appear in the blood. That is the lag time. Now, don't misunderstand. Just because you start to get drug into the blood does not mean that the drug automatically starts to work. You have to wait for the plasma levels to rise in the blood until you reach a very important point called the minimum effective concentration, or the MEC. The minimum effective concentration is where you're first seeing the pharmacologic effect of the drug. That is when the drug is first having its actions in the body. So when we go to our terminology here, from time 0 to the MEC, that is the onset of activity. Notice that it includes the lag time in that period there. Now, once a drug crosses the MEC, continues to rise in the plasma. It's still working, of course. It's going to reach a peak. It's going to take a certain amount of time to get there. When it reaches that peak, of course, once you're at the top, no place to go but down, so you start to decline. As the plasma levels decrease, you're going to come to a point where you cross the MEC once again. And of course, once you cross it and are down below it, this is all part of your process of elimination. But once you cross that MEC, you have really defined now the point called the duration of action. It's from where you first cross the MEC and really the period of time where you stay above the MEC. So from when you first cross to when you cross it again in the process of elimination. So duration of action. Can you influence drug absorption? Can you change the slope of this curve? And of course the answer to that is absolutely. One of the ways that people can commonly do that is to take antacids, for example. Antacids are going to raise the pH of the stomach, and that's going to decrease absorption, you should be able to predict, of weak acids. Okay? But increasing the pH of the stomach might actually increase the absorption of weak base drugs. And of course, you can change the elimination curve as well. You may not want to, but you could see a decline in renal function. And if that happens, you could actually see that the duration of action of a drug could be extended because of decreased renal elimination. Next, we're going to look at the concept of bioavailability. We've mentioned this once before, but when you think about bioavailability, it really relates to the area under the curve for some orally administered dose to the area under the curve for an IV administered dose. Notice that IV really is our standard here, our reference for this. Why? Because when you take a drug IV, its bioavailability is 100%. So really what we're doing in this comparison is we're trying to see if the route that we've chosen, for example oral, has the same bioavailability as the standard here, which is IV. So that's what the diagram is showing here. So this is an IV administered drug. Notice the exponential decrease over time in plasma concentration. And then here's the orally administered dose, increasing, reaching a peak, and then falling away over time. So really when you compare, you'll notice that there's an overlapping region for these two areas under the curve, and that's what's shown right here. But in order to effectively compare, you're basically asking this question: does this shaded region equal this shaded region? Or at least does this region here come close to an IV administered dose? And you can't predict that with certainty by just simply looking at the graph, but just visually you would say that those are pretty close, indicating that your orally administered dose is pretty close to your IV. In other words, it's pretty close to 100%. Now let me reassure you that you won't be asked to calculate bioavailabilities on your exam. However, you will need to understand a couple of things. And first of all, it's that we use the letter F to stand for bioavailability. And why F? Well, it's F for fraction of the dose. The fraction of the dose that reaches the systemic circulation. That's what really defines our bioavailability. And of course, if this number is less than 100%, you can imagine that you're going to have to modify your dosing equations. And you'll see that we have to do that in things like a maintenance dose or a loading dose calculation. One of the things that greatly influences the bioavailability of a drug is the first pass effect. Okay? And the first pass effect, of course, refers to the fact that when you take a drug orally, it goes directly into the portal circulation and is initially certainly sent to the liver. Okay? For some drugs, that effect of the liver, that very rapid metabolism, will dramatically reduce their bioavailability. And that's what we call the first pass effect. And kind of a way to think about this is that when you take a drug orally, the liver is going to get the first opportunity to do something to that drug. And that could be to significantly metabolize it and lower its plasma levels. And so when you look at the visual that's shown here, again, by mouth, the drug goes into the stomach, makes its way into the portal circulation, it gets churned around in the liver, and whatever makes it out the other side, that really is our bioavailability. And that could be all of the dose originally, or that could be a very small amount of the dose originally. Two examples here. The first one is lidocaine. Now, if you were to take lidocaine orally, what's going to happen is that it's going to go through this process, and when it gets to the liver, its metabolism is going to be so extensive that the amount of drug that comes out on the other side into the systemic circulation is going to be very, very low. Okay? So lidocaine is not very effective at all by the oral route. Therefore, IV is preferred to make sure we have the bioavailability for the drug to work. A second example, nitroglycerin. Of course, when you think about nitroglycerin, you could be thinking about treating an acute angina attack. And the way that we take nitroglycerin in that case is sublingual. Advantage of the sublingual route, when you put the drug under your tongue, you get a very rapid absorption with very little first pass metabolism. So sublingual is actually a way to avoid some of the first pass effects. Clearly injectable routes, IV and IM, are ways to avoid first pass as well, but sublingual does a pretty good job of avoiding first pass metabolism, and that leads to a pretty rapid onset of action for nitroglycerin. Our next part of pharmacokinetics is drug distribution. Now, if you think about this whole setup behind pharmacokinetics, essentially what we're talking about is we're talking about a story here where a drug is taken, it gets absorbed, it goes into the bloodstream, and now it's going to be distributed throughout the body. Okay? So this involves the processes where the drug is moving throughout the body, okay, to the various organs and tissues. The conditions that affect distribution. Well, under normal conditions, protein binding capacity, okay, which of course is much larger than is the drug concentration. Therefore, the free fraction of the drug is generally constant. Of course, many drugs bind to plasma proteins, and you might imagine that's simply because drugs are designed to be lipid soluble, and therefore they need a carrier in the blood. And there's going to be an equilibrium between the bound and the free molecules. And that's really shown very nicely in this diagram. Remember that the free drug is the active form of the drug. That's a very important point. When the drug binds to plasma proteins, and of course you might be thinking about albumin as being the most likely plasma protein here, that form is going to be inactive, okay, when the drug is bound. So let me ask you a question. Would you consider albumin a receptor for a drug? And of course the answer to that is no. Albumin would not be a receptor for a drug, and the reason is that a true receptor is going to give you a biologic response when it's bound by a drug. And the response from albumin is to simply just take the drug along for a ride in the plasma. Okay? There's no biologic response elicited. In fact, plasma proteins are what we call inert or inactive binding sites. Now, a very important point, and arguably the most important point here for your exam related to distribution, is this point right here, that there can be competition between drugs for plasma protein binding sites, which may increase the free fraction, okay, possibly enhancing the effects of the drug displaced. Since many drugs are lipid soluble, therefore many drugs are bound to plasma proteins. And if you're taking multiple drugs that are bound to plasma proteins, you can certainly get an interaction based off of one drug being displaced from plasma proteins. I'm going to give you two examples. The first one is here in your notes. It's sulfonamides and bilirubin in a neonate. Now in this particular example, obviously not a drug-to-drug, but a drug-to-bilirubin effect. And of course, bilirubin is bound to albumin. Sulfonamides are bound to albumin. And essentially by adding the drug, by adding the sulfonamide, you're going to displace bilirubin, increasing bilirubin levels, of course leading to kernicterus in the neonate. A second example I'll give you here is with warfarin. Okay? And the example here, warfarin plus sulfonamides. Okay? Warfarin, of course, is a drug that interacts with lots of drugs. Here, an example of it interacting with sulfonamide antibiotics once again. Warfarin is about 98% protein bound, leaving only about 2% of it free in the plasma. Makes it a prime candidate for drug interactions. If somebody's on warfarin, let's say that you've stabilized their bleeding times, everything is going fine, and sometime later they get an infection. Okay? And perhaps you start them on an antibiotic, and maybe that antibiotic is a sulfonamide. What's going to happen is the sulfonamides are also wanting to bind to albumin. They're going to displace warfarin, thereby increasing its plasma levels, and as a result, you get a greater toxicity from warfarin. Again, keep in mind, the exam is not going to come right out and say, observe the following drug interaction. You must be able to predict what type of drug might cause this effect. If you know the patient is on warfarin, for example, how would you recognize warfarin toxicity? Well, of course, bleeding or bruising would be side effects that you might recognize from higher plasma levels. What might cause higher plasma levels of warfarin? It could be competition for plasma protein binding sites. So sulfonamide antibiotics would be worth knowing that they're also highly protein bound and can have this type of an effect. In terms of barriers to distribution, it's really incorrect to think about the placental barrier as being a very effective barrier, because the rule is that most drugs can cross the placental barrier. Certainly if they're small molecular weight drugs or if they're lipid soluble, and since many drugs are lipid soluble, of course, drugs can get into the placenta. Now, the blood-brain barrier is a very effective barrier, and only highly lipid soluble drugs are those of very low molecular weight can actually get into the brain. Of course, we have plenty of lipid soluble drugs. Let's go with the second point here, low molecular weight drugs. What would be some examples of that? Well, a couple of examples would be lithium and ethanol, both of which can get into the CNS. Now, think about lithium. Why is it a surprise that lithium can get into the CNS? And of course, you should notice the positive charge. The fact that lithium is positively charged, you would think would be a deterrent to its movement in the body because of it being in an ionized form. But the reality is, lithium is the smallest drug we have. It's so small, in fact, that it easily moves across the blood-brain barrier. Now, ethanol can also get into the CNS. Why is that a surprise? Well, because ethanol is an alcohol. It's polar. It's very water-soluble. Why does it get into the CNS? Because it's very small. Okay, so again, these are rules related to how small these drugs are. Now, how about a rule for you related to both of these barriers? And the rule is that if a drug can cross the blood-brain barrier, it will easily cross the placenta. Okay? And that doesn't always mean that it's going to have harm to the fetus, but certainly in the case of drugs like lithium or ethanol, there's that potential. And both of those potentially have toxic effects to the fetus. Okay, a couple of other examples to look at here. What if your goal was to design a safe drug in pregnancy? So here's our clinical vignette. What would be some of those properties of the drug? Well, how about if the drug was water soluble? It would be less likely to cross the placental barrier. What about if the drug was large? The bigger the drug, the less likely it is to get in. And finally, what about if the drug is highly protein bound? Okay? If it's highly protein bound, again, you've increased the size, therefore you're unlikely for the drug to actually cross into the placenta and have an effect on the fetus. And really related to the protein bound category here, when you think about this, that's probably how you choose between drugs. Okay? Many times drugs within a category, the one that is more highly protein bound is the one that's actually preferred in pregnancy. An example would be propylthiouracil versus methimazole. I mean, think about it. What's going to happen if you use one of these anti-thyroid drugs and they get into the fetus? Well, they can cause cretinism. Okay? They can decrease the size, obviously, affect the limbs, cause mental retardation. So clearly, you don't want an anti-thyroid drug to cross the placental barrier and affect the fetus. If you had to choose between PTU and methimazole, most likely you would choose PTU. And one of the reasons is because PTU is more highly protein bound than methimazole. Methimazole, in other words, would be much more likely to cause cretinism. And a second example of highly protein bound drugs is the drug phenobarbital. If you think about the use of anticonvulsants, many of our very popular and important anticonvulsants are teratogenic. You might be thinking about drugs like phenytoin and carbamazepine and valproic acid, which are obviously teratogenic, and if possible, you would want to avoid them in pregnancy. But phenobarbital, highly protein bound, is actually considered one of the safer anticonvulsants and is commonly used in pregnancy. We also have the concept of the apparent volume of distribution, again abbreviated V sub D in this case. What VD does is it correlates the dose to the plasma concentration. And this plasma concentration is actually the plasma concentration at 0 time. And I'll remind you that when you administer a drug, as it's being distributed, the plasma concentration is going to dramatically change over time. Especially if you're given this drug IV, for example, you're going to see a dramatic decrease in the plasma concentration. So it's actually very difficult to predict or calculate the initial plasma concentration because of this change. But this is still a very important equation for you to know. And I would argue that there's the possibility that you'll get an exam question related to using the VD equation. Most often, in that particular calculation, they're going to give you the initial plasma concentration and even give you the volume of distribution, and you're going to be asked to calculate the dose. Okay? So dose is the most likely parameter to calculate. Now, of course, the points here tell you that the relationship can be used for calculating only if you know C0. That's why I point out the exam is going to have to tell you what C0 is. If you look at the relationship between VD and plasma concentration, you could predict that VD is low when a high percent of the drug is bound to plasma proteins. Now, why is that? Because binding to plasma proteins are going to keep the drug in the plasma. You're going to have a higher amount in the blood. If this number is high, this number is going to be low. VD is high when a high percent of the drug is sequestered in tissues. Right? If the drug is being sequestered in tissues, it's obviously not staying in the plasma very effectively. If this number is low, this number is going to be high. So the predictability that you can think about here related to these variables is going to be very important. Of course, if you've got a high percentage of the drug being sequestered in tissues, it raises the possibility of being displaced in those tissues. Examples would be verapamil and quinidine, both of which can displace digoxin from tissue binding sites. And that particular drug interaction would actually enhance digoxin toxicity. When you think about this concept as well, you want to think about some normal physiologic values. And of course, we often refer to the ideal 70 kilogram man. And when you think about the values for the ideal 70 kilogram man when it comes to plasma volume, about 3 liters. When it comes to blood volume, about 5 liters. Extracellular fluid, 12 to 14. And total body water, usually we talk about 42 liters, 60% of body weight being total body water. And when you think about the concept of VD and start to apply what's a low volume of distribution or what's a high volume of distribution, it's good to keep these numbers in mind as far as what could be a real physiologic value. The question here really that VD is answering is, where is the drug? That's really what it's saying, is where is the drug? And we've already said that if most of the drug is in the plasma, then the volume of distribution is low. If most of the drug is actually outside of the plasma, then the volume of distribution is going to be high. Now, as far as some real numbers for VDs of drugs, there's really quite a range. From low volumes of distribution in single numbers, 4, 5, 10 liters even would be lower numbers. But keep in mind that since physiologically we've got 42 liters of water in our body, if you're that 70 kilogram man, then any number below 42 sounds physiological, or even around 42 sounds physiological. But how about on the other end of the spectrum? What if you had a drug that had a volume of distribution of, say, 4,000 liters? What does that number really tell you? If you see 4,000 liters as the volume of distribution, what would you predict about the plasma concentration? Clearly, it's got to be very, very low. So where is the drug really if you've got a VD of 4,000 liters? And of course the answer is it's outside the plasma being sequestered in the tissues. And it really isn't a surprise that volume of distribution contributes to our half-life equation. Changing VD is going to change the half-life. Okay, one more point related to volume of distribution. And it's really in how the exam might actually present this number to you. Most often VD is going to be given to you in liters. Okay? 4, 5, 10, 4,000 liters, for example. But what if they give you liters per kilogram? Actually, this is the more useful way to see volume of distribution expressed. Why? Because you can factor in the weight of the patient. And if you see liters per kilogram as the way VD is expressed, clearly that's an indication you've got to multiply by the patient's weight, okay, to get to liters. So keep that in mind depending on how you see volume of distribution. We also have the concept of redistribution. Okay? Redistribution is actually how some drugs are handled within the body, because in addition to crossing the blood-brain barrier, very lipid-soluble drugs can redistribute, of course. Where's the lipid-soluble drug going to go? It's going to go into the fat prior to elimination. And in the case of CNS drugs, this could be an important concept because the duration of action of an initial dose may actually depend more on redistribution than on its half-life. And there's really no better example in my mind than this particular clinical vignette on the drug thiopental. Thiopental is an IV anesthetic. You know that when you inject this drug, it has a very rapid onset. Okay? Reaches the brain in less than a minute. And it actually diffuses back out of the brain fairly rapidly as well. And so you tend to think about this as a short acting drug, very rapid onset, very rapid recovery. But you probably have never thought about the fact that this drug has a half-life of 9 hours. It actually lasts for a long time in the body. Why does it have such a long half-life but such a short duration? And the answer to that is redistribution. The drug goes into the brain quickly, comes back out of the brain, gets redistributed into the fat where it's sequestered for a long period of time. Again, the drug is not having an effect, it's just being sequestered in the fat, so it's got a long half-life. And this diagram actually will help you to visualize that. When you take the drug like thiopental, first thing is that it's going to rapidly move into the CNS. Okay? Rapidly moving into the CNS. It will slowly move into the fat. Okay? The drug can come back out of the CNS, back into the blood, okay? And it also can come back out of the fat into the blood. But imagine if you give subsequent doses of this drug. Okay? If you continue to take thiopental repeatedly, some of that drug is already being sequestered in the fat. So multiple doses of thiopental will still lead to a rapid movement of the drug into the CNS, but the movement into the blood, or rather into the fat from the blood, will actually be much more slow. Why? Because you're starting to accumulate drug in the fat. And if the drug accumulates into the fat, this movement right here is going to be even slower, leading to the drug staying in the blood and possibly moving back into the CNS. So for drugs that are redistributed, multiple doses of those drugs can actually begin to saturate the fat and increase the effect, increase the duration of action of those drugs. Our next topic is biotransformation. And of course, biotransformation is just really another way of saying drug metabolism. And the rule in metabolism is that we're trying to take lipid-soluble drugs and convert them to more water-soluble forms. And of course, the reason for this is that those forms are more readily excreted. Now, biotransformation or metabolism of drugs can really have one of three different types of pathways, and those are shown here. Most often, I would imagine, you think about metabolism as an inactivation process, where you're taking a drug that's active and converting it to an inactive metabolite. And of course, that's good to remember because that's what happens with most drugs. Most drugs are active as given and then are converted by metabolism to inactive metabolites. But don't think about biotransformation or metabolism as always being inactivating. There are times when it's an activating process, and that's what's shown here. You can take a drug, and even a drug, for example, that's active as given, and that drug can be metabolized to active metabolites. A very classic example of this is the clinical correlate that you can see there on benzodiazepines. Now, many benzodiazepines are active as given and then metabolized to active metabolites. And those metabolites are very essential to the actions of the drug. Okay? Very important, in fact, for their effects. And finally, the last example is where you have a prodrug, which maybe reminds you of something like a prohormone, which has to be processed. In this case, has to be metabolized to an active form. So the last two steps here of drugs forming active metabolites or prodrugs forming an active drug are showing you metabolism as an activating reaction. Many prodrugs, as it turns out, are actually antimetabolites. This is a term that we're introducing now, but you'll hear a lot more on antimetabolites. These are compounds that in essence look like metabolic products found in the body. And you might remember many antiviral drugs and several anti-cancer drugs are actually antimetabolites, where they're inactive as given and have to be converted to the active form In many of those cases, it involves the process of phosphorylation in order to activate the drug. When you think about metabolism, you tend to think about phase 1 and phase 2 metabolism reactions. Let's focus first on phase 1. Now, phase 1 involves usually one of 3 types of reactions, and I'm going to highlight those for you here. Those are oxidation, reduction, and hydrolysis. Okay? Probably a good idea to remember those as your 3 main phase 1 reactions. But when you think about phase 1, I would argue that almost always you think about cytochrome P450 enzymes. Now, this is a large family of enzymes. In fact, there's about 13 different families of these with about 100 different enzymes. Again, that's not a point to memorize, but just to give you some perspective on this particular category of enzymes. Now, cytochrome P450s are found in the smooth ER. We call that the microsomal fraction. P450 enzymes have an absolute requirement for oxygen and NADPH. A lot of these reactions are oxidations, which include hydroxylations and dealkylations. And of course, there are many of these families, as I've indicated up here. This is going to be a very important table for you, and I say that at the risk of you automatically trying to spend time and memorize this table. And let me just say, for example, when it comes to substrates, you don't need to sit down and try to memorize all the different substrates. So let's hit the most important points first. When it comes to cytochrome P450 enzymes, we identify these as various families and subfamilies. So for example, there's a family called the 1A2 set of enzymes. There are the 2C9, the 2D6, and the 3A4. And of course, this is not all of the enzymes, but just some representatives, and certainly some important representatives of the cytochrome P450 family. Now, when I say don't try to memorize substrate examples, some of these you think would be pretty easy because it's not hard to memorize, say, 2 drugs in this particular section. But if you go down here to the 2D6 family, notice it says many cardiovascular and CNS drugs. Well, how many drugs are in that particular box? And the answer to that is a lot. How about the 3A4 family, which I would argue is the most important of the P450 families? Why? Because this particular family metabolizes 60% of all the drugs that we have. So how many drugs are in this box? Several hundred drugs are actually in this particular substrate box. So again, not worth your time to try to memorize specific substrates. What is important for you to understand is exactly what an inducer of P450 enzymes is and exactly what an inhibitor of those enzymes would be. Let's take an example of what an inducer would be, and I'm going to have you highlight cigarette smoke. If you're a smoker, there are hydrocarbons found in the cigarette smoke called benzopyrenes, and those benzopyrenes actually are components there that can induce P450 enzymes. For example, if you're a smoker, you're going to induce your liver to make more 1A2 enzymes so that any drug you take that's metabolized by a 1A2 enzyme is going to be metabolized at a greater rate. How about a concrete example? What if you're a smoker and you're taking theophylline? If you smoke and then sometime later you start taking theophylline, you're going to metabolize theophylline faster than a non-smoker because you're going to have more enzymes there. And as a result, your plasma levels of theophylline are going to be lower than compared to a non-smoker. So of course, you have to make a dosage adjustment for smokers, which would be to increase the plasma levels of theophylline. Now keep in mind, that's a very classic scenario and one that you need to be aware of for your exam. But recognize the exam sometimes will take a common scenario and twist it slightly, turn it so that you have to think one more step. So let's imagine that you're a smoker and you're on theophylline. You've assumed that you've had to make dosage adjustments to account for the smoking. Sometime later you convince this patient to stop smoking. What dosage adjustment are you going to have to make now that the patient has stopped smoking? Well, clearly in that case, you're going to have to lower theophylline levels back down, or else you run the risk of theophylline toxicity. So be able to work both ways when it comes to plasma levels and P450 inducers. Most of the time, though, you're going to be thinking about the inducer just simply lowering the plasma level of the substrate. Now, inhibitors are very popular questions on the exam. because inhibitors of P450 enzymes are going to lead to a decreased amount of the particular enzyme family, and that's going to lead to an increase in the amount of substrate. Let's take an example here of a patient with chronic bronchitis. Okay? This is our clinical vignette. Patients with chronic bronchitis are often on multiple medications, and if I ask you, what is your therapeutic strategy? At least your main strategy in treating chronic bronchitis. I would argue that your first strategy is to bronchodilate, and that your second strategy is to bronchodilate, and then your third strategy is also to bronchodilate. So this person is going to be on multiple bronchodilators, and it wouldn't be a surprise to find this particular patient on the drug theophylline. Once again, we'll use this as an example. Now, if the patient is on theophylline, you're already concerned because theophylline is a fairly dangerous drug. It's got a low therapeutic index, a topic we'll be covering shortly. So what else do patients with chronic bronchitis need? Well, most often these patients experience recurrent respiratory tract infections. And because they get those recurrent respiratory tract infections, they might need an antibiotic. And what's a good antibiotic for many respiratory tract infections? And that would be macrolide antibiotics. Macrolides are very classic P450 inhibitors. Predict, what are the macrolides going to do to the plasma levels of theophylline? And you should say they're going to increase. What's going to happen? How is that patient going to present? Well, that patient is going to present with theophylline toxicity. So that's a very classic scenario with a particular condition where the patient might actually be on both of those drugs. And again, Step 1 of your boards are going to be looking for those types of very obvious and classic scenarios to make sure you understand exactly what's going to happen in that case. Again, there are lots of inducers and lots of inhibitors. We're going to cover a few of these specifically on the next slide. These are all mentioned for you at the bottom of that table. So classic P450 inducers. Phenobarbital is one. All barbiturates, but really phenobarbital is the most classic inducer. Phenytoin and carbamazepine. Two drugs that I would argue whenever you say phenytoin, you should probably also say carbamazepine because they go together in many, many ways, including the fact that they both induce P450 enzymes. The antibiotic rifampin is also a classic P450 enzyme inducer, and chronic alcohol. Okay? Chronic alcohol, and you'll notice that alcohol shows up as both an inducer and an inhibitor. Chronic alcohol is obviously drinking over time, usually small amounts on a daily basis, drinking chronically but not necessarily to excess. Then the list of inhibitors is also very important to remember. Of course, cimetidine, I would argue, is the most classic inhibitor and probably the most important for you for your exam, if for no other reason than it's readily available over the counter. Many times you'll get an exam question where a patient is self-medicating for ulcers. Okay? If a patient is self-medicating for ulcers or stomach pain, you might want to think about the possibility of them taking cimetidine, a drug that can interact with many different drugs. Macrolides, really among the macrolides, erythromycin is the one that you're most concerned about having a P450 effect. The one macrolide that tends to have no P450 inhibitory effect is the drug azithromycin. Okay? So erythro and then clarithromycin to some extent has an inhibitory effect, but azithromycin does not. The antifungal drug ketoconazole, very, very classic inhibitor as well, one to remember. The AVIRs, you might remember these as antiviral drugs, and specifically these are protease inhibitors used in HIV. So all of the drugs that end in AVIR, the AVIRs, are P450 inhibitors. There's acute alcohol. Again, to distinguish it from chronic, acute alcohol would actually be drinking to excess, which I would argue would inhibit most things that you try to do, including drug metabolism. And finally, we have grapefruit juice. Okay? Grapefruit juice actually has a note there in your margin, and we'll take a look at that. The clinical correlate on grapefruit juice reminds you that there are active components in grapefruit juice that inhibit the metabolism of many drugs. One of the drugs listed there in that particular margin note is atorvastatin. And so I'm going to highlight the statin drugs. And the reason I'm making this particular connection for you, again, look for an obvious thing here. Why would a patient be taking a statin in the first place? And of course you would respond, because they've got high cholesterol, high LDLs. Besides offering that patient a statin, what else would you recommend that they do? Well, you should say they should change their diet. They should exercise more. And perhaps they're going to take your advice. They decide to change their diet. And what if they decide to start drinking grapefruit juice every day for breakfast? Well, they've caused a very classic drug interaction here. The grapefruit juice inhibiting the metabolism of the statin, resulting in higher statin plasma levels and statin toxicity. You might think of things like muscle toxicity, for example, or some liver damage. There are certainly other types of phase 1 reactions besides cytochrome P450 enzymes, so-called non-microsomal metabolism. Hydrolysis, the addition of water molecules to break bonds. Esterases and amidases, you might think about local anesthetics in that case. Genetic polymorphisms with the enzyme pseudocholinesterase, and I'm going to give you a clinical vignette related to this. A deficiency in pseudocholinesterase caused by this genetic polymorphism is going to result in an increase in succinylcholine levels. You know, succinylcholine is a classic skeletal muscle relaxant that's metabolized by the enzyme pseudocholinesterase. Monoamine oxidases metabolize amines, as the name would imply. Certainly there are various endogenous amines, dopamine and norepi and serotonin, that are all metabolized by monoamine oxidase. There are also exogenous compounds, and tyramine is the most classic of these. You should remember where tyramine is found. Tyramine is found in certain types of beer, but importantly, red wine and cheese, aged cheese in particular, and fish are places where you find tyramine. Of course, there's a very classic drug interaction, which we'll cover later on, between tyramine and the enzyme that metabolizes it, monoamine oxidase, and specifically inhibitors of that enzyme. And then finally, alcohol metabolism. Alcohols are metabolized to aldehydes and further to acids by a series of dehydrogenase enzymes, and there are some polymorphisms that exist there as well. Now, phase 2 metabolism really is a completely different type of reaction that's happening here, because these are what we call conjugation reactions. And the term conjugation really means that you're going to attach something to the drug. And if you're going to attach something, you're actually transferring some molecule to the drug itself. And so in order to transfer, to conjugate, you need an enzyme called a transferase. So one of the properties of phase 2 reactions is that they all involve transferase enzymes, and that's an important point to keep in mind. There are several types of phase 2 reactions. We're only going to cover a few of these here that are really, really important for your exam. The first of these is glucuronidation, which is really the most commonly utilized of the phase 2 reactions. Now, glucuronidation has several important features. For one, it's inducible. You may see some enterohepatic cycling of the conjugate, but this is an extremely important point right here, that you see reduced activity in neonates, and that's going to lead to my first example here. The first clinical vignette is with chloramphenicol. Chloramphenicol toxicity, which you probably remember in a neonate shows up as gray baby syndrome. But of course the question then becomes, why? Why do you see gray baby syndrome with chloramphenicol? Well, it really relates to an inability for the neonate to effectively metabolize this drug. Why can't a neonate effectively metabolize chloramphenicol? It's because it has low levels of the enzyme glucuronosyl transferase. This is the enzyme that's involved in the conjugation reaction we call glucuronidation. So you can't really metabolize chloramphenicol very effectively if you've got low levels of glucuronosyl transferase. A second example would be a deficiency in this enzyme. A deficiency in glucuronosyl transferase could show up, for example, in Gilbert syndrome or also in Crigler-Najjar. Now, of course, in Gilbert syndrome, more of a benign condition. You've got really an increase in circulating bilirubin, about 60 to 70% of normal, of an increase. You certainly see high levels in those cases caused by a deficiency in glucuronidase. You also see something similar in Crigler-Najjar, type 1 versus type 2. Type 1, a complete lack of bilirubin conjugation, bilirubin glucuronidation specifically, caused by a deficiency in glucuronidase. So both of those pathologic conditions relate to a deficiency in this enzyme. Our second type of phase 2 reaction is acetylation. In acetylation, you've got a genotypic variation. In other words, you have what's called fast and slow metabolizers, or fast and slow acetylators, if you will. So essentially the population falls into those categories. And if you're a fast acetylator, that means you're going to rapidly metabolize drugs by acetylation, and that's not going to be a problem. However, if you're a slow acetylator, you're going to be slow to metabolize drugs by acetylation, and that's going to result in accumulation of certain drugs that are metabolized by that pathway. And importantly, you can get a drug-induced SLE, a drug-induced lupus, if you're a slow acetylator and you take certain drugs. And hydralazine is one very important drug here. Hydralazine, of course, is a vasodilator used in severe hypertension. You also have to worry about drug-induced SLE with procainamide, the antiarrhythmic, and isoniazid, the TB drug. Of course, when you think about drug-induced lupus, a pretty classic scenario that shows up on your exam, so you need to recognize the features of drug-induced lupus. Of course, butterfly malar rash and a positive anti-nuclear antibody test are also typical of non-drug-induced lupus. So those are not distinguishing features between drug-induced and non-drug-induced lupus. However, the presence of antihistone antibodies only shows up with drug-induced lupus. And my favorite thing to look at here is if you were to discontinue the drug and the lupus symptoms disappear. That's a pretty typical example there of showing you that it was caused by a drug. Okay? It doesn't always happen that the symptoms go away just because you stop the drug, but classically that's what you expect. The last type of phase 2 reaction is glutathione conjugation. And glutathione conjugation is important for a variety of reasons, and of course the classic hepatotoxic drug is acetaminophen. You see a depletion of glutathione on overdose, and that's what leads to the toxicity. There's not enough glutathione to detoxify the reactive metabolite of acetaminophen. Next, we have the kinetic section of elimination. I'm going to encourage you, when you think about drug elimination, to make it synonymous with the term termination. Elimination is when you terminate the actions of a drug. The processes involved in elimination are basically two important components here. One, it's biotransformation. Biotransformation, or metabolism, to inactive metabolites. Okay? Most commonly, drugs are metabolized by the liver, and metabolism to inactive metabolites is a major form of elimination. Secondly, we've got excretion by the kidney. Okay? Drugs are oftentimes eliminated by excretion in the kidney. Of course, both of those are forms of elimination or termination of drug action. And I would caution you about getting excretion confused with elimination, because certainly excretion is a type of elimination. But drugs can be metabolized to an inactive form long before those molecules are actually excreted from the body. In that case, metabolism is the major form of elimination. Of course, there are other routes of excretion. Bile ducts, lungs, sweating would be ways to get rid of drugs. It also allows us to talk about the concept of half-life, the time to eliminate 50% of a given amount of drug, or to decrease that plasma level to 50% of a formal level, would be the definition there of half-life. Now, when you think about elimination rates, we have zero order and first order elimination rates. Importantly, when it comes to zero order, you want to read this statement very carefully. A constant amount, and I'm going to highlight amount because that's your key word. A constant amount of drug is eliminated per unit time. Now, the rate of elimination is independent of the plasma concentration, or frankly the amount of drug in the body. Drugs with zero order elimination have no fixed half-life, so several important points about zero order kinetics are listed there. So in other words, half-life is going to be a variable, and we'll see that in this example. First of all, which drugs undergo zero order elimination? Because we have three that we always point out as being extremely important: ethanol, phenytoin, and salicylates, but arguably really you're thinking about aspirin in that case. So you've got three drugs, and you probably should come up with some way to remember those three. The way that I've come up with to remember those three drugs is to have a play on the word zero. So since it's zero order kinetics, if you take the first letter of each of those three drugs, PEA, zero P's for me. Okay? So you've got phenytoin, ethanol, and you've got aspirin. So the concept really, when you think about zero order, you should be thinking about saturation kinetics. Okay? You're saturating the elimination mechanisms. In other words, if it's enzymes involved in eliminating the drug, those enzymes are working at their maximal velocity to eliminate the drug. You have maxed out. So when you think about saturation, you're most often thinking about high doses of these drugs. It's certainly true for phenytoin, where it's high therapeutic doses. Certainly is true for aspirin, where it's the high therapeutic, but especially the toxic doses that are going to be zero order. The one of these three that's different is ethanol. Ethanol, except at the very low blood levels, is going to be zero order. So even at kind of the medium levels of ethanol, and certainly to the higher levels, you're going to see zero order kinetics. The example that's shown here assumes that you start with 80 milligrams of drug, and you find out that after 4 hours, you're down to 70 milligrams. So you'll notice that you've eliminated 10 milligrams of drug in 4 hours. Then you go from 70 down to 60. Once again, you've eliminated 10 milligrams of drug. 60 down to 50, once again, 10 milligrams. And 50 down to 40, finally, 10 milligrams. Notice how each time interval here, each 4-hour period, we eliminated 10 milligrams of drug. Okay? And that's what's very important here. It's a constant amount of drug being eliminated per unit time. Certainly you can think about zero order kinetics graphically. If you plot time versus units of drug, and you do this on a linear scale, you're going to get a linear decay, as indicated by this graph. If you plot time versus log units of drug, a semi-log plot, you're going to get this type of curve, showing elimination for zero order. Compare that to first order elimination rate. In first order elimination rate, you're really looking at a constant fraction of the drug, and so I'm going to highlight that word. Fraction is really the key. A constant fraction is eliminated per unit time. Notice, not a constant amount. Now, the rule is most drugs follow first order elimination kinetics. Okay? This is typical enzyme kinetics. In other words, the enzymes are not working at their Vmax. Importantly, half-life is a constant. Okay? Half-life is not variable in the case of first order elimination. If you look at this example, you start with 80 milligrams, except this time you're told that the half-life of the drug is 4 hours. So you go from 80 down to 40 milligrams in 4 hours, 40 to 20 in 4 hours, you cut 20 in half down to 10 in 4 hours, and 10 down to 5 in 4 hours. But importantly, to make your comparison between first order and zero order, go back and count the amount of drug that you lost each unit of time. The amount that you lost in this first 4-hour period was 40 milligrams. The amount that you lost in the second time interval was 20. And in the third time interval, it was 10 milligrams. And finally, you lost 5 milligrams in the fourth interval. Notice how the amount is changing per unit time. Okay? So that's the rule. In first order, the amount is not constant. The amount is going to change per unit time. 40 to 20 to 10 to 5. How about an example of using half-life that actually doesn't count on you using the half-life equation? It's an example where maybe you're told, patient comes to the ER. They have 5 milligrams of drug in their body. Okay? Related to this example in your notes. Patient says she dosed 8 hours ago. Okay? How much drug did she ingest? Well, if you know that she has 5 milligrams right now, you know that the half-life of the drug is 4 hours, you know that she dosed 8 hours ago, you can assume that 2 half-lives have passed. So to figure out how much drug that she ingested originally, you just simply have to double the amount twice. There's 1 half-life, takes you to 10, and a second half-life takes you to 20. So she ingested 20 milligrams of drug to end up with 5 milligrams now, 8 hours later. A nice way of looking at half-life without having to do a calculation. Of course, when it comes to the graphs, the shape of the first curve here is quite different. Notice that when you plot time versus units of drug, first order kinetics shows this exponential decay. But if you plot time versus the log units of drug, you see this linear type of decay. And what this should remind you of is exactly the shape that we saw for zero order kinetics on a linear scale. So you have to be careful about paying attention to your graph here and your units. Whether it's a linear scale or it's a semi-log plot is going to make a difference since you've got graphs that look very, very similar. Now I'm going to give you a rule in just a minute on how to compare that's independent of simply memorizing the shape of the curves, but recognize that this is a challenge for you. So when we look at this graphic analysis, you look at this curve here, first thing maybe you want to decide is, am I looking at first order kinetics or zero order kinetics? If you analyze your graph, notice that you're plotting time on a linear scale, plasma levels on a log scale. So of course on a linear scale, notice how the numbers are evenly spaced, and the linear scale usually starts at 0. Log scales don't usually start at 0, and notice how the numbers are not evenly spaced. So again, when you look for those hints, pay attention to your axes to make sure you're understanding exactly what you're looking at here. So this is a semi-log plot, and you see this type of linear decay. Now maybe you memorized what type of kinetics that was, but you also need to pay attention to exactly some factors that can help you predict what type of kinetics it is. And the first one of these I would pay attention to is really the half-life. Can I determine a consistent half-life off of this graph? The way that you would do it graphically is you would pick a plasma level. Let's say we pick the plasma level of 4. If I want to determine the half-life of this drug, I want to take the plasma level of 4 and see how long it takes to go from a plasma level of 4 and reduce it down to a plasma level of 2. So if you start with 4, you go over until you intersect with your curve, then you come down, and you see that on your time interval that's about 3 hours. The point is about right here. Then if you go to the plasma level of 2, go over until it intersects with the curve, and come down, that's about 6. And the interval between those 2 points is actually 3 hours, and that represents your half-life. So right now you've used one set of data points to determine a half-life. I would argue never stop at one set. Always look at another set of data points to see if you get the same answer. So let's take the plasma level here of 6 and see how long it takes to go from 6 down to 3. If you take 6, go over to your line and come down, that's a little past 1. Here's 3, go over to your curve till it intersects and come down, and that's a little past 4. That interval there is also 3 hours. So what you found is that you have a consistent half-life. Remember, only in first order kinetics do you get a constant half-life. So this has to be a graph of first order kinetics. And finally, from this graph you can also estimate C0. Now I think there's a low probability of you being asked to do this on the exam, but remember, since the plasma concentration changes very rapidly, notice in this graph you're coming down. This first phase of the graph where you're coming down, very brief phase where you see this slope, that really represents the distribution phase of the drug. And when you get to this long linear portion right here, that represents the elimination phase of the drug. So clearly during the distribution phase, plasma level is changing so rapidly, very hard to determine C0. So what we do is we extrapolate from the long linear portion of the curve, the elimination portion of the curve, back to the y-axis. And if you extrapolate back, you can actually get on the y-axis here an approximation of C0. Again, low chance of you having to do that on your exam, but you could actually estimate C0 from a graph like this as well. Next, we're going to look at renal elimination. Of course, renal elimination is really a function of the GFR plus how much drug is actively secreted minus how much drug is reabsorbed. Of course, filtration is a non-saturable linear function, and we've already seen that both the ionized and the non-ionized forms of the drug are filtered, but not the protein-bound drug. Now, clearance really is defined as the volume of blood cleared of drug per unit of time, and it's constant in first-order kinetics, so it's constant for most drugs. What if you had a situation where there was no reabsorption or secretion? Well, then in that case, clearance is going to equal GFR, okay? Assuming no plasma protein binding, okay? Importantly there. We use inulin clearance to estimate GFR, okay? Because inulin is not reabsorbed or secreted. So a normal GFR, normal inulin clearance of 120 mils per minute is what you expect. Of course, you've also got the scenario where drugs are protein bound, and this is very, very common. Since protein bound drug is not cleared, you need to factor in how much of the protein bound drug, or how much of the free drug, in fact, that's going to get filtered, knowing that the protein bound drug will not be filtered. So the equation that you use there is very straightforward. The clearance is equal to the free fraction times the GFR. Okay, let's look at two examples now. First example is, what if the actual clearance of a drug is less than GFR? Okay, what type of processes would be going on if the actual clearance of the drug is less than GFR? And you might say, for example, that drug must be reabsorbed. But if the actual clearance of the drug was greater than GFR, then clearly you must have some active secretion going on for that drug. Okay? And the other example I'm going to give is if you're given the situation of a protein-bound drug trying to figure out renal clearance. Keep in mind that this is the equation that you're going to use, but most often a question is going to give you the percent of the drug that's protein-bound. Okay? If you're told how much is protein-bound, for example, if you are told that the drug is 80% protein-bound, pretty easy to infer if 80% is bound, then 20% is free, so that represents the free fraction. So the clearance would be, in that example, 20% times the GFR. Our next concept is steady state. Now, steady state is reached when the rate in is equal to the rate out, or when the values associated with a dosing interval are the same as those in the previous interval. And of course, achieving a steady state in the plasma is really a goal that we use in our maintenance dose equations. We're trying to achieve and to maintain a steady state. We refer to steady state as the plateau principle because ultimately as the drug rises in the plasma, we're trying to reach that plateau. Okay? The time to reach steady state is dependent only on the half-life of the drug. Very important to remember that only the half-life of the drug is what's going to predict the time that it takes to reach steady state. It's independent of the size of the dose, and it's independent of the frequency of administration. You've got a very classic graph here looking at the rise to steady state. Again, looking at time versus plasma drug concentration. The goal here is to administer a drug at various intervals to achieve a plateau or a steady state in the plasma. And you'll notice I've added a couple of labels, and we will talk about the minimum toxic concentration and the minimum effective concentration and how that relates to this graph. But let's start first with the graph. If you start at time 0 and you administer a drug, let's say in this example you're giving 100 micrograms per mil of the drug. The half-life of this drug is 4 hours. So you're going to wait one half-life till the plasma level goes down to 1/2 of the original value, so down to 50, and then you're going to dose again with the same amount. So you're going to give 100 micrograms per mil and achieve a plasma level of 150. Wait a half-life, which is 4 hours, go down to 75, and then dose again. So now you're up to 175. Wait a half-life down to 88, dose again up to 188. Half-life takes you down to 94, dose takes you up to 194. And if you continue on that pattern, you're going to achieve a steady state. Notice that's achieved when you're oscillating between these 2 points, between the peaks and the troughs that you observe down here at the bottom. Okay? The peak values and the trough values. Recognize that all of your peak values are going to be obtained after you've dosed. The peak value, for example, after the first dose was 100 micrograms per mil. At steady state, the peak value is going to be twice that level, or 200 micrograms per mil. The trough values, of course, are all going to occur before the first dose. So kind of a silly question, what was the trough level before the first dose? The trough level before the first dose, of course, was 0. The trough level before the second dose, the trough level was 50. After that first dose was 100, but before the second dose, the trough level is 50. Before the third dose, 75. So all of these numbers in the bottom here represent your trough doses. And you can answer any question related to particular plasma levels, either before or after doses. Of course, at steady state, you're oscillating between 2 numbers, and those 2 numbers in this example are 200 and 100, back and forth at steady state. If you wanted to approximate an average of those 2 numbers, you could draw a line right through the middle of this curve to represent your CSS average. Okay? Because the concentration at steady state at the peak would be the CSS max. The concentration at steady state at the trough level would be the CSS minimum. Okay? And again, you're oscillating between those 2 values. When you think about this type of curve, really your goal is to maintain a steady state plasma level of the drug that is above the minimum effective concentration even at the trough levels, and that the curve is actually below the minimum toxic concentration, especially at the peak levels. In essence, what these 2 terms are defining is what's called your therapeutic window. You want to keep your curve on your rise to steady state in between these 2 numbers, inside this window, in order to be effective but not toxic. In terms of some tips about time to steady state, okay, the rule is this, that you get halfway to steady state in 1 half-life. You get 90% of the way to steady state in 3.3 half-lives. And importantly, and here's the one to definitely highlight, that in 4 to 5 half-lives, you're about 95% of the way there, which in essence is close enough because we call this clinical steady state. Okay? So one more time. It takes 4 to 5 half-lives for a drug to reach clinical steady state. And that's really the number that you must know. Important to distinguish also that clinical steady state is not the same as mathematical steady state. In fact, it takes greater than 7 half-lives to reach mathematical steady state. As clinicians, we're really not concerned about the mathematical time. We're really way more concerned about the time that it takes to reach clinical steady state. And in a particular question, with several pharmacokinetic values of a drug, one of those values that they will list would be the half-life. And maybe the question goes on to ask you how long it takes to reach steady state. Remember, the only value you're going to look at in that question to determine time to steady state is the half-life. What if you're told the half-life of the drug is 5 hours? Okay? If the drug has a half-life of 5 hours, 5 times 4, 20 hours, or 5 times 5 to 25 hours is how long it's going to take to reach clinical steady state. Okay, so just simply multiply the number by 4 to 5. Rest assured the exam is not going to give you both of those numbers, only one to ask you how long it takes to reach steady state. In terms of the rate of infusion, again, the time to steady state is going to be the same irrespective of the rate of infusion. Okay? It does determine the plasma level at steady state. So in other words, if you give more drug, you're going to reach a higher plasma steady state level. You're just not going to reach that level any faster than if you gave a lesser amount of the drug. A similar relationship can exist for other forms of drug administration, for example, oral. And again, you can reach steady state by any of a variety of ways of giving drugs. Doubling your oral dose can double the plasma levels of a drug, for example. So if you look at this particular diagram, what you should recognize is you're really looking at 5 different infusion rates. In fact, 5 different maintenance doses is what you're looking at. And those 5 different maintenance doses, obviously 1, 2, 3, 4, and 5 milligrams per minute. Again, plotting time versus plasma drug concentration. And what should you notice about this curve? You should notice that every one of these curves plateaus at the same time. They all level off at the same time. In other words, their time to steady state is the same, regardless of how much drug you gave, whether it was 1 milligram per minute or 5 milligrams per minute, all are going to rise and plateau at the same time. Now, I didn't say that these 5 curves are exactly the same. I just said that the time to steady state is the same. What is the difference in giving 1 milligram per minute, say, versus giving 5 milligrams per minute? Well, notice you're plotting versus plasma concentration here. If you give 1 milligram per minute, you're going to reach a much lower level in the plasma compared to 5 milligrams per minute. Okay? But you won't reach that level at steady state any faster than you did if you gave 1 milligram per minute. Next, we're going to look at the effect of a loading dose. Since it takes 4 to 5 half-lives to achieve clinical steady state, sometimes you just can't wait that long. It may take a long period of time to reach that steady state depending on the half-life of the drug, and that might be a situation where you want to use a loading dose. Now, a loading dose is designed really to more rapidly achieve effective drug levels in the blood, and it's really equivalent to giving a bolus of the drug, most often one time, a one-time only bolus. So it's estimated to put the amount of drug in the body that should be there at steady state. Of course, if the doses are administered at each half-life and the minimum effective concentration is equivalent to the CSS minimum, then the loading dose is twice the amount of the maintenance dose, and we'll highlight that. Okay? In our previous example, we were giving a maintenance dose of 100 micrograms per mil. So a loading dose in that situation would be double that amount, or 200 micrograms per mil. Again, assuming normal clearance and same bioavailability for maintenance doses. The equation here for loading dose is concentration in the plasma times the volume of distribution. Now notice that we only have 2 variables that we're really concerned about here. The concentration in the plasma, which is our target plasma level, and our volume of distribution, which is going to help to predict exactly where the drug is going to go in the body. And you might be thinking that giving a loading dose sounds like a good idea really all the time. Why wouldn't you always want to rapidly achieve effective blood levels? And the answer is, of course, since you're giving a large bolus, it can be potentially dangerous. So you don't always want to use a loading dose because you are giving a large amount of drug, many times for the first time to a patient. So you want to reserve this strategy for certain situations, and one of those could be where it's maybe more of an emergency and you really can't wait that long to take effect. So if you look at this example, and I'm going to use the example of the drug digoxin. Okay? Digoxin has a half-life of almost 2 days, so you should be able to calculate that it's going to reach clinical steady state in 8 to 10 days, a long period of time. In fact, if you followed the graph here at the bottom, and let's imagine that this is giving digoxin only by maintenance dose, and this line represents the MEC, the minimum effective concentration. If you give digoxin only by maintenance dose, notice that the first dose doesn't even reach the MEC. Okay? So in essence, you've lost a couple of days right there. The next dose does get above the MEC, but it doesn't stay there for very long. And only until the 3rd dose and the 4th dose will you start to get to plasma levels that are going to maintain a level above the MEC. Again, if it's a life-threatening arrhythmia, you can't wait that long in that type of situation. So that would be a case where you would want to use a loading dose. Okay? And if you gave a loading dose, most often that loading dose is going to be twice the maintenance dose. Its primary purpose is to give you a spike in the plasma, a level that's clearly above the MEC, so that the drug is going to start working and have its effect in the body right away. If you then follow that loading dose up with a maintenance dose, you can help to maintain plasma levels that are above the MEC. So importantly, if a loading dose is done one time, a one-time only bolus. If you only gave a loading dose, of course that plasma level would drop all the way back to 0. But if you follow the loading dose up with a maintenance dose, the combined levels of those two doses together can help you to achieve levels that stay above the MEC. Lastly, in this section we have some pharmacokinetic calculations. Some single-dose equations include one that we've reviewed already, the volume of distribution equation, dose divided by C0. We've already talked about that. That would be a good equation for you to know for your exam. Remember, they're most likely to give you C0 and VD and ask you to calculate dose. Secondly, we have the half-life equation. And while there's a possibility that you're going to be asked to calculate this equation, I think there's a greater chance that you'll be asked just simply to use your knowledge of this equation in order to answer a question. So knowing the equation either way is still valuable. The half-life is equal to 0.7 times VD divided by clearance. And I'll point out the relationship between these variables. Do you notice that half-life and volume of distribution are directly proportional? For example, increasing the VD is going to increase the half-life, assuming clearance stays the same. And notice also that clearance and half-life are inversely proportional. Okay? And you know, of course, that if renal function declines and you decrease renal clearance, that the half-life is going to go up. The drug is going to last longer in the body. So understand the relationship between the variables to understand that equation. Multiple dose or infusion rate equations are shown next. The infusion rate, the K0, is clearance times your CSS. Okay? And that infusion rate equation fits in very nicely as part of the maintenance dose equation. Notice essentially that the maintenance dose is the infusion rate times tau. Now, tau, of course, is your dosing interval. It's how frequently you're going to dose. That could be once a day, that could be 4 times a day, and anything in between. So tau is your dosing interval. Notice also that the maintenance dose equation factors in clearance. In other words, if you're going to give a drug over time, which is what you would do with a maintenance dose, you must know what the kidneys are doing. You must know what renal clearance is. So clearance is a very important variable in your maintenance dose equation. Notice that in the loading dose equation, clearance is not factored in, only volume of distribution. Again, this is not done over time, so renal function is not considered for a loading dose equation. Notice also that both equations, both the loading dose and the maintenance dose equation, factor in F. Remember, F is bioavailability. Now, of course, if the question told you that the drug was administered IV, then you know that the F value is 1 because it's all available. It's 100% bioavailable. So if an F value is 1, then you don't have to worry about changing your calculation. However, if the bioavailability is less than 1, you're going to have to adjust your dose accordingly. If it's 0.8 or 0.5, you're going to have to divide by F. Finally, both loading dose and maintenance dose equations factor in some type of plasma concentration. Okay? For the loading dose, it's really more of a target plasma concentration because you're not really trying to maintain a steady state with a loading dose. You're just trying to get to a certain plasma level. But it is technically correct to say that with a maintenance dose equation, you're trying to achieve a CSS, a concentration at steady state that can be maintained in the plasma. And of course, maintenance dose over time, loading dose usually one time only. The next chapter in general principles that we're going to look at is a chapter on pharmacodynamics. This is the section that's going to allow us to review the mechanism of action of drugs as well as to start to predict why some of these drugs might cause certain side effects. We'll start with some definitions. The first definition we're going to review is agonist. A drug is called an agonist when binding to the receptor results in a response. Ultimately, it stimulates that receptor. Whereas an antagonist is a drug that, when it binds to the receptor, does not give you a response. In fact, the drug has an effect only by preventing an agonist from binding to the receptor. And that's the key there. Only by preventing an agonist from binding to the receptor. In fact, it's correct to say that an antagonist simply blocks the actions of the agonist. Some other definitions to pay attention to, first of all, would be affinity. The affinity of a drug for binding to its receptor on a dose-response curve is shown by the proximity of the curve to the y-axis. But importantly, you can only compare affinities on a dose-response curve if those curves are parallel. And specifically, you're looking at the slopes of the curves. And the rule is this: the nearer the curve is to the y-axis, the greater the affinity. Next, we'll talk about potency. Now, potency shows the relative doses of two or more agonists to produce the same magnitude of effect. And on a dose-response curve, this is shown by the proximity of the curve to the y-axis. Should remind you in many ways of affinity in terms of that type of comparison. There is an important caveat to potency. The caveat is you can compare potencies if the curves do not cross. And we'll see some examples of that. Finally, we have efficacy. You should always think about efficacy as really the effectiveness of a drug, and it's shown by the maximal height reached by the curve. There's a bridge to biochemistry in your notes there that relates a couple of these terms to some biochemical terms that you've used before. First of all, when you think about affinity, affinity is inversely proportional to the KD. The KD is the drug concentration required to give you half maximal binding to the receptors. And it's analogous to Km in enzyme kinetics. And when it comes to efficacy, certainly when you're thinking about efficacy in terms of the maximal effect, what's termed the Emax, this is very similar to the maximal velocity, or Vmax, that you learned about in biochemistry. We're going to look at some dose-response curves now, plotting the doses versus the response for various agonists that activate receptors, and this will give us some information and some predictability about affinity, potency, and efficacy. These types of curves are called graded or quantitative dose-response curves. First, we'll do a comparison of drug A and drug B. First thing we want to do is compare affinities. Really, we first want to decide, can we compare affinities? And the way that we're going to do that is we're going to ask ourselves this question: are the slopes of these curves parallel? And of course, the answer to that is yes. And if the slopes are parallel, that means drug A and drug B work on the same receptor. And therefore, we can compare their affinities. When you compare affinities, the one that is shifted more to the left, closer to the y-axis, is the one that has the greatest affinity. So you would say that A is greater than B when it comes to affinity. Next, let's compare potencies. Remember, the rule on potencies was that you can compare unless the curves cross. Notice that these curves do not cross each other. While they're going to intersect at the top, they actually will not cross. Therefore, we can compare potencies. And what would we say? Well, potency comparison is a lot like affinity. The curve that's shifted more to the left, closer to the y-axis, is the one with the greatest potency. So we would say that A is more potent than B. When it comes to efficacy, there really is no caveat on efficacy. You can always compare the effect of the drug. Here, you'll notice that both A and B reach the same height. They both reach 100% response on our dose-response curve. Since they have the same height, they have the same efficacy. Therefore, we'll put up there that they're equal in efficacy. Let's make the same comparisons with drug X and drug Y. First thing you want to notice is, can we compare their affinities? And you'll notice that their slopes are not parallel. What conclusion do you draw from the fact that their slopes are not parallel? You would conclude that the drugs work on different receptors. Drug X has its own receptor, and drug Y has its own receptor. Since they're different receptors, you cannot compare their affinities. Can we compare potencies? Certainly. Notice how the curves do not cross. The curve for X is always going to be taller than the curve for Y. So what you would say is that since the curve for X is shifted more to the left, X is more potent than Y. When you think about potency and the whole concept of the curves crossing, you might take this example here and decide, when are the curves ever going to cross? What about if we flip the order of these two curves? Could you imagine if Y was to the left of X, that eventually that curve would cross, the curve for drug X? And in that case, that would violate our rule about comparing potencies. And we'll see more on that coming up shortly. Lastly, let's compare the efficacy of drug X versus drug Y. And you'll notice that drug X reaches the 100% mark. On our graph, drug Y falls short of that. So clearly drug X has a greater efficacy than drug Y as well. Last, let's do some practical applications of these concepts and ask you this. Which one of these terms, affinity, potency, or efficacy, is clinically the most important? I would argue that it's efficacy. You're really most concerned about the effect that a drug can produce and not so much about the dose required to produce that effect, and that's really what potency is telling you. It's the dose that's required to produce a particular effect. And while affinity is interesting and certainly an important pharmacologic concept, from a therapeutic standpoint, not really the most important therapeutic principle here. When we explore the concept of agonist further, we realize that we have what's called full and partial agonist. A full agonist, as its name implies, can produce a full or maximal response. They have maximal efficacy. Oftentimes we don't use the term full agonist. We simply use the term agonist, and the term full is implied. If we want to designate an agonist as something other than full, we call it a partial agonist. And as its name implies, it's going to give you a partial response. Okay? These types of drugs are incapable of giving you the maximal response, so they are less effective than full agonists. Let's talk further about full and partial agonists, this time by looking at a dose-response curve. So if you imagine here we're plotting the log dose of the drug versus the percent response. And I told you that all three of these drugs are agonists. It's pretty easy to see that only one of these drugs gives you the 100% response. In other words, gives you a maximal effect, and that of course is drug B. Therefore, drug B is a full agonist. Drug A and drug C fall short of the 100% response, and therefore pretty easy to see that those are partial agonists, and they're going to give you a partial response. Now, if you do a comparison here of efficacy, pretty easy to see that drug B has a greater efficacy than drug A or drug C. But drug A and drug C, it looks like, have the same efficacy. Why? Because they reach the same height. What about comparing potencies? What if we compared the potency of drug A to drug C? You should be able to see, since the curve for A does not cross the curve for C, that we can make a comparison. What we would say is that since drug A is shifted more to the left, closer to the y-axis, that drug A is more potent than drug C. What about a comparison of B versus C? Well, drug B does not cross the curve for C. It's shifted more to the left and closer to the y-axis, therefore B is also more potent than C. So we can summarize that this way. A is greater than C and B is greater than C when it comes to potency. But there's a comparison that we haven't made yet. It's a comparison of drug A versus drug B. There's a problem with this comparison, and that is, what if we were to continue to add more drug A and we were to extend this curve out? You'll notice that eventually drug A, the curve, will cross the curve for drug B. So we really can't absolutely compare A and B because the curves cross. Certainly that's our rule. However, if we specified certain doses, we actually could make a comparison. Here's what we would find. For example, what if we picked a low dose of drug A, maybe a dose right here on our x-axis, and we ask ourselves this question: what is drug A doing at that dose? The answer would be that drug A is giving us a response around 30 to 40%. Now, what if we gave that same dose of drug B? What is drug B doing at this particular dose? And the answer to that is nothing. Drug B is having no effect. So at that chosen dose, which drug is more potent? And the answer is drug A. But since the curve for A is going to cross the curve for B, at the intersection of those two curves, if we were to come down to our x-axis and find that dose, any dose that we gave above that particular point, we would find that drug B is actually more potent than drug A. For example, if we chose a dose out here on the far right, and we go up to where A would be, it would be right about here. That would be A, somewhere around about 70% on our response scale. At that same dose, notice that B has already peaked at 100%. So if B was at 100, A was at 70%, drug B is more potent than drug A at all the doses above the concentration where the two drugs intersect. So we would make a summary by saying A is more potent than B at low doses, B is more potent than A at high doses. And that's why we can't make an absolute statement, an always type of statement saying that A is always more potent than B, because that's not true. Let's talk further about the concept of partial agonist and really explore what's called the duality of partial agonist, really the double property of these types of drugs. And what you should recognize is that both full agonist and partial agonist are going to bind to the same receptor. So you could imagine there's going to be a competition. Both drugs will try to bind. If the full agonist binds to the receptor, you're going to get essentially a full type of response, whereas the partial agonist is going to give you a partial response. Let's explore this concept with an example. The example is the drug Pendolol. Now, Pendolol is a drug you should recognize as a beta blocker. It's an olol, so the ending is what gives it away. Of course, Pendolol is not only a beta blocker, it's actually a partial agonist beta blocker. And the partial agonist property of this drug means that it actually has some ability to stimulate beta receptors, albeit a weak ability to stimulate those receptors. And to kind of illustrate what would happen in the body with Pendolol, let's do kind of an artificial experiment where we take a test tube and we put a heart in the test tube. And if we add some Pendolol to that heart, its partial agonist property in that test tube will cause that heart to beat. Okay? If we took a second test tube and we put a heart in there and we added a full agonist like epinephrine, this time when we add the epinephrine, the full agonist heart is going to beat much more rapidly. So if you think about those two examples, you've got the Pendolol heart beating slowly, you've got the epi heart beating rapidly. If you come up with a third experiment, a third test tube, where in that third test tube you put a heart in there and this time you added some Pendolol and some epinephrine together. My question is, how is that third heart going to beat? And the answer, of course, is that it will beat somewhere in between the two rates that we've seen so far. If this was the partial agonist heart rate and this was the full agonist heart rate, when you mix them together, you'll get some number in between. So ultimately, what is Pendolol doing in that example? Pendolol is actually antagonizing the action of the full agonist, in this case of epinephrine. And that third example is really the realistic example. That's what's going on in the body. In the body, whenever somebody takes Pendolol, it's always going to be there in the presence of catecholamines like epi and norepi, and you're not going to have a situation where that person is not going to have catecholamines present. So the test tube example is artificial, but it at least gives you an idea of what a partial agonist drug can do. So let's take that understanding and apply it to this graph. Imagine when we plot the log dose of the drug versus the response, if the response was heart rate, so that it fits into our example with Pendolol. So that as we add Pendolol to the isolated system, the isolated test tube system, you would see an increase in the heart rate. So that would be Pendolol all by itself. Again, that's not reality because that's not what happens in the body normally. But Pendolol could stimulate the heart. What if we also plotted next to this graph a dose of a full agonist like epinephrine? Well, you would see that that dose would reach 100%. What if once we reached a 100%, at that point, let's say right here, we started adding in the partial agonist Pendolol. So if this was epi all by itself, giving you 100% response, as we add Pendolol, we start to see the heart rate go down. Essentially, as we add more and more Pendolol, we get a greater and greater antagonism, so that eventually we get to the point where the curve looks like Pendolol alone. You'll notice that the curve is never going to go all the way to zero. Why? Because the partial agonist can still have some ability to stimulate those receptors. Just simply in the presence of a full agonist, it actually works as an antagonist. The whole concept of antagonism is further explained in this graph, where we're going to look at both competitive and non-competitive inhibitors. Of course, the first thing you've got to do is recognize that in the middle of your graph here is the control. Now, the control in this experiment is, in essence, the agonist. This is the comparison that we're going to make. This is the agonist, and so the x-axis here is actually plotting the log dose of the agonist. If you add a competitive antagonist into the system in the presence of an agonist, you're going to generate a dose-response curve that's shaped very similar, in fact, identical to that generated for the agonist. Now, I will tell you that most drugs that are antagonists are competitive. This is the rule. You expect that if you know that a drug is an antagonist, you should assume that it's competitive, because very few drugs in pharmacology, in fact, are non-competitive. The question is, why do you get the same shaped curve? Well, it's all because of the way that the antagonist binds to the receptor. Remember that when an antagonist binds to the receptor, it binds almost always by very weak ionic bonds. So the drug binds to the receptor but quickly lets go of the receptor. And as a result of that transient interaction of binding and letting go, the control drug, the agonist, can then bind to the receptor. So remember, we're plotting the agonist concentration on the x-axis here. So in the presence of a competitive inhibitor, if we just simply add more agonist, how would you see that on the curve? Moving it to the right. Adding more agonist can overcome the action of the competitive inhibitor, and therefore you generate the same curve, but simply shifted to the right. Since it's shifted to the right, it kind of reminds you of a decrease in potency, because it's going to take more agonist now to get the full response in the presence of a competitive antagonist. Now the curve for the non-competitive drug is really shaped quite a bit different. Notice how it's not so much shifted to the right as much as it's shifted down. Now, non-competitive drugs, I mentioned, are kind of the exception. You don't see a lot of these in pharmacology, and I would argue that most often when you do see them, it's an important point to remember. So I'm going to give you a list of non-competitive drugs here. Again, this is not all of them, but these are many important non-competitive antagonists to be familiar with. You might remember the drug phenoxybenzamine. Phenoxybenzamine is a non-competitive alpha blocker. It blocks both alpha-1 and alpha-2 receptors. Digoxin, of course, one of our cardiac drugs, CHF, and antiarrhythmic. Digoxin is an irreversible non-competitive inhibitor of the sodium-potassium ATPase in the heart. Allopurinol, one of our gout drugs, non-competitively inhibits xanthine oxidase. PPIs, proton pump inhibitors, drugs like omeprazole, that work in the stomach to inhibit the proton pump, which is a hydrogen-potassium ATPase. And then, of course, aspirin. Aspirin, which is going to irreversibly inhibit cyclooxygenase. So again, this is not all of your non-competitive drugs, but it is a very high-yield list of important non-competitive drugs, all of which are going to generate a dose-response curve that looks like this when compared to an agonist. And once again, when you think about a non-competitive drug binding to the receptor, many times those non-competitive drugs actually bind irreversibly to the receptor, but importantly, because of their ability to be non-competitive, simply adding more agonist is not going to generate the full response. Notice how the curve is shifted down. In the presence of a non-competitive inhibitor, you cannot get back to your maximal response. So what does a non-competitive curve remind you of? Basically, a decrease in efficacy. Okay? The efficacy is shifted down. And notice how that is completely different from a competitive antagonist, where you can still get the full efficacy, okay? Though it looks like it's going to take more drug, and it looks like a decrease in potency. So an important difference between the shape of these curves. And you could certainly envision a question where the exam will not only ask you to remember that some of these drugs are non-competitive, but they may ask you to visualize them on a dose-response curve as well. So that would be an important point to remember. Lastly, we have the concept of potentiation. Potentiation in pharmacology is actually a rare event. It's rare that you're going to see a dose-response curve shift to the left. Okay? An example of this would be benzodiazepines plus GABA. Okay? And of course you remember what a benzodiazepine can do by mechanism. It's going to work through the GABA A receptor, and it's going to increase the frequency of chloride channel opening. Of course, in this example, you should imagine that the agonist to compare to would be GABA all by itself. So of course GABA can open up that chloride channel as part of the GABA-A complex all by itself. But if you add a benzodiazepine into the mix, you're actually going to enhance or potentiate the actions of GABA. Again, potentiation maybe helps you to think about a change in potency. In fact, it looks like an increase in potency, which in this case is shown by a shift to the left. It's kind of the opposite of what's going to happen with a competitive antagonist, where you get a decrease in potency and a shift to the right. Okay? So benzos plus GABA would be a good example to remember for potentiation. Of course, when it comes to antagonism, we've just discussed pharmacologic antagonism, which really comes in the form of competitive and non-competitive antagonism. But importantly, this involves the same receptor. And maybe you can diagram this type of antagonism this way. You could imagine that you've got two drugs, both of which are trying to interact with the same receptor. One drug is an agonist, the other drug is an antagonist. But in this example, you have two drugs working at one receptor. So that's what we mean by same receptor. You can identify the type of antagonism simply by counting the receptors involved in the response. Okay? So we won't go through all the points here related to competitive antagonists. We saw this on the diagram. Okay? But competitive and non-competitive antagonists are examples of what we call pharmacologic antagonism. Our second type of antagonism is physiologic antagonism. And notice the notes tell you different receptor. You could profile this way. You could diagram that you've got drug number 1 interacting with receptor number 1, and then drug number 2 interacting with receptor number 2. Notice two drugs and two receptors. And in this case, the two receptors are going to have an opposite response. Okay? Whatever receptor 1 does, receptor 2 is actually doing the opposite. So we need an example. How about a vasoconstrictor with a vasodilator? If you want a more specific example even than that, think about a drug like phenylephrine. Phenylephrine is an alpha-1 agonist. It's going to vasoconstrict when it interacts with those alpha-1 receptors. And of course that would increase TPR and increase blood pressure. Compare that with a vasodilator. Say a drug like nitroglycerin, which works through nitric oxide. Nitric oxide, of course, is going to vasodilate and lower TPR and blood pressure. Now, phenylephrine and nitroglycerin don't work on the same receptor. In fact, they work on different receptors that have an opposite effect. Whenever you see that phenomena, describe that as physiologic antagonism. Lastly, we have a type of antagonism called chemical antagonism. Now, as the name implies, it's a chemical interaction, which you might diagram this way. Chemical antagonism is where drug number 1 interacts directly with drug number 2. Notice that there are no receptors involved in this type of antagonism. It's simply a drug-to-drug interaction. So an example of chemical antagonism would be protamine binding to heparin. Independent of any receptors now, one drug, protamine, binds to another, heparin. And a second example of chemical antagonism would be metal chelators. You might think about drugs like succimer or dimercaprol or deferoxamine, which can bind up to various heavy metals. And that's a direct drug-to-drug interaction and is a good example of chemical antagonism. And then we've also talked about potentiation with benzodiazepines. Next, we have these quantal or cumulative dose-response curves. Really a different type of dose-response curve to look at here. These curves plot the percentage of a population, and I'm going to highlight that word because one of the ways to think about this type of curve is to think about it as a population curve. Okay? You're comparing your drug and its response in the population. From these types of curves, you can actually estimate the median effective dose, what we call the ED50, or the dose that's effective in 50% of the population. You can also use these types of curves to calculate a therapeutic index. Now, therapeutic index gives you a measure of the relative safety of the drug. Therapeutic index along with therapeutic window, which we mentioned earlier, are both good estimates of the safety of a drug. And with a therapeutic index, you're actually going to compare the toxic dose 50 which is the dose that's toxic to 50% of the population. Rarely, of course, in animal models, we might perhaps look at an LD50, the lethal dose in 50% of the population, and compare that to the effective dose 50. So most often, this is the equation that you're going to use. The therapeutic index is the TD50 divided by the ED50. When we look at the therapeutic index, you can actually calculate a therapeutic index by using this type of curve that shows you the therapeutic response as well as the toxic response in the population. So here you're plotting the dose of the drug in milligrams per kilogram versus the percent response. But importantly, this is the percent of people responding to your drug. So from 0% to 100%, everybody is going to respond at some level to the therapeutic levels of this drug and at some level to the toxic effects of this drug. So if we have these curves and we want to calculate a therapeutic index, remember that this is a function of the TD50 over the ED50. So the first thing we want to calculate is the TD50. The way that we do that is we go up to the 50% response in the population, then we go over to where that curve intersects with our toxic dose curve, and we come down and read the number off of the x-axis. Highlighting that here for you, you can clearly see that that number is 10 milligrams per kilogram. Then we need to know the effective dose in 50% of the population. Once again, go to the 50% mark, come across to the curve, come down and read off of your x-axis. And of course that number would then be 2 milligrams per kilogram. So our therapeutic index for this drug would be 10 divided by 2, which equals 5. Now, essentially what that number tells you is that if you took 5 times the recommended dose of this drug on average in the population, that you're going to get toxicity, okay, if you took 5 times as much. And clearly, we want this number to be as large as possible. You want this number to be up around 50 or 100 or even larger, so that you've got a wide variation between the therapeutic curve and the toxic curve. Of course, some drugs have fairly low therapeutic indices, numbers like this one down in the single digits, and some that are down around 2 or even slightly less. Clearly those would be the more dangerous drugs that are out there with a low therapeutic index. I'm going to give you a high yield list of drugs with a low therapeutic index. Now this is not all the drugs that have a low therapeutic index, just several that are very important for you. Theophylline, which we've used as an example a few times now, for example back in drug metabolism. Digoxin, warfarin, and lithium. And certainly there are many others that may come to mind that you could add to this list. But I will tell you, as far as a board strategy goes, that the lower the therapeutic index for a drug, the more likely it is to show up on the exam, especially in a drug interaction question. So these very low therapeutic index drugs, very dangerous type of drugs, are very common because they're important in their own right, as well as the fact that if you raise their plasma levels slightly, you're going to get a pretty significant effect on drug toxicity. One more point before we leave this curve. Steep curves are really what you want. A steep curve with a very steep slope actually indicates very little patient variability. Okay? It's when these curves are flatter that you can actually get quite a bit of overlap, maybe between your therapeutic range and your toxic range. So preferably you would like to have a steep curve and curves that are far apart to indicate relative safety of that type of drug. Next we're going to move into the signaling mechanisms part of our notes. And this is a great section for some dovetailing between pharmacology and biochemistry, because this is going to give us an opportunity to review several mechanisms that drugs are going to use, and we'll go through several examples as well. But all of these mechanisms have a biochemistry basis, so it's a good place to tie in biochemistry with your pharmacology. First, we're going to look at intracellular receptors, including receptors for steroids. Okay? Now, receptors for steroids, the binding of the hormone or the drug is going to release regulatory proteins that are going to permit activation, and in some cases, dimerization. So I'll highlight binding and dimerization. The hormone binds, and most often you form a dimer. That complex is then going to translocate to the nucleus, where it's going to interact with response elements in spacer DNA. that particular interaction is going to lead to changes in gene expression. Okay, so clearly you're familiar with this type of system. If not, make sure you read through and get comfortable with this. You might think about drugs such as glucocorticoids, binding to glucocorticoid receptors and changing gene expression, for example, of proteins that inhibit inflammatory mediators. A characteristic of this pathway is that the responses elicited via modification of gene expression are slow. Okay? They're slower in onset, but the trade-off is they tend to be longer in duration. Think about it this way. It's going to take time to make new proteins. So glucocorticoids, for example, are going to stimulate those various new proteins to work as anti-inflammatory effects, and as a result, it's going to take a little bit of time to make those proteins, but once you make them, you're going to have a long-lasting effect. So besides the glucocorticoids we've talked about, thyroid hormones, gonadal steroids, and even vitamin D fit into this section. Next, we have membrane receptors that are directly coupled to ion channels. Many drugs work this way by mimicking or even antagonizing the actions of various endogenous ligands that affect the flow of ions. Now, notice that this system does not utilize second messengers. Okay? It's a receptor that is directly coupled to an ion channel. Okay? No second messengers involved here. A good example is the nicotinic receptor for acetylcholine, which is present in a variety of locations in the autonomic nervous system at the ganglia, at the neuromuscular junction, and also in the CNS. This receptor is directly coupled to either a sodium or potassium ion channel. It's the target for many drugs. Of course, nicotine would be a target for the nicotinic receptor. Choline esters or ganglion blockers or skeletal muscle relaxants, many drugs that you will cover in the autonomic nervous system section. And very similar to that would be the GABA-A receptor. Remember, GABA-A, found in the CNS, coupled to a chloride ion channel, and certainly many drugs, anticonvulsants, benzodiazepines, barbiturates can manipulate and modify the action of that receptor. Next, we have a very important section on receptors linked via coupling proteins to intracellular receptors, and this is a section where we're going to talk about G proteins. Many of these G proteins are coupled directly to adenylyl cyclase. That, of course, is the enzyme that converts ATP to cyclic AMP. Cyclic AMP is a second messenger that's going to promote phosphorylation by activating protein kinase A. It's important to highlight that protein kinase. Protein kinase A, an easy way to remember, A goes along with adenylyl cyclase. Now, these receptors are typically serpentine-shaped receptors, 7 transmembrane spanning domains, the third of which is coupled to the G protein effector mechanism. So, a little bit of terminology. We tend to talk about adenylyl cyclase as the effector molecule, and we talk about cyclic AMP as the second messenger in this system. Now, protein kinase A serves to phosphorylate a set of tissue-specific substrates, okay, or various transcription factors, the Krebs, thereby affecting their activity. Among the different types of G proteins, we have GS proteins. You might think of S for stimulatory G proteins, and binding of an agonist to a stimulatory G protein is going to increase cyclic AMP. So the effector molecule for this type of signaling system is adenylyl cyclase, and it leads to the production of cyclic AMP. Now, receptors that are important. While there are many receptors that are important in this pathway, all betas are GS, okay? And that's important to remember. All betas, beta 1 and beta 2 in particular, are of very good importance there. You also have the dopamine D1 receptor. The dopamine D1, found in renal vasculature, where it's going to cause renal vasodilation, is also coupled to a G sub S protein and increase cyclic AMP. Finally, the histamine H2 receptor also utilizes a G sub S signaling system. And of course, prostacyclin and many serotonin receptors utilize this pathway as well. The GI proteins, in many ways, you should think about GI as the opposite of GS. So GS is stimulatory, GI is inhibitory G proteins. Now, the effector molecule for GI proteins is still adenylyl cyclase, except this time Binding of the agonist is going to inhibit adenylyl cyclase, and it's going to decrease cyclic AMP production. So it is pretty obvious that this is an opposite effect to what we see with the GS system. Some receptors to pay attention to here for GI. First, we have the alpha-2 receptor. Next, we have the muscarinic M2 receptor, both of which are very important autonomic receptors, and the dopamine D2 receptor, very important in the CNS. Certainly, opioid receptors and serotonin receptors, some of the serotonin receptors also utilize this pathway. The third type of G protein we're going to look at are the GQ proteins. Now, GQ proteins are really quite different from GS or GI, with the main difference being that they use a different effector molecule. No longer do the GQ proteins use adenylyl cyclase, they're going to use the effector phospholipase C. The enzyme phospholipase C is going to then release second messengers such as IP3 and diacylglycerol from membrane phospholipids. IP3, of course, is going to release calcium from the sarcoplasmic reticulum, which together with diacylglycerol helps to activate protein kinase C. So notice that we have another protein kinase here to pay attention to, protein kinase C, which matches up very nicely with phospholipase C as a way to remember that. Protein kinase C then goes on to phosphorylate tissue-specific substrate enzymes, usually not phosphorylated by protein kinase A, and thereby affecting their activity. Various receptors utilize GQ signaling systems. Important ones for us to highlight are receptors for acetylcholine, specifically the muscarinic receptors M1 and M3. M3 receptors, of course, found throughout the autonomic nervous system in the periphery. M1 receptors really found in high concentration in the CNS. Secondly, we've got the alpha-1 receptor. Alpha-1s are obviously very important, for example, in controlling blood pressure, where they're found on blood vessels, and they're activated, of course, by norepinephrine as well as epinephrine. Of course, other receptors here, like angiotensin II and several serotonin subtypes, also work through a GQ signaling pathway. Very nice diagram here to look at exactly what's going on with these different types of G proteins. If you look over on the left side at adenylyl cyclase, remember the two types of G proteins that work through adenylyl cyclase as the effector are GS and GI. Through the GS system, and you see the structure there, the 7 transmembrane domains, the alpha, beta, and gamma subunits of these G proteins. Of course, remember that it's the alpha subunit that's really the working end of this particular molecule. When you think about activating the GS proteins, activating GS is going to form cyclic AMP, and that cyclic AMP is then going to activate protein kinase A, which then goes on to phosphorylate a variety of tissue-specific proteins. GI, the opposite, going to decrease the formation of cyclic AMP and thereby decrease the activation of protein kinase A. On the right-hand side, the GQ type of system, GQ is going to use also the 3 subunits here, alpha, beta, gamma. Again, the alpha subunit is the working end of this. The major active component is the alpha subunit. Activating GQ is going to activate phospholipase C. Phospholipase C is then going to cleave PIP2, producing IP3, which goes and releases calcium from the sarcoplasmic reticulum, and diacylglycerol, which is going to help to activate protein kinase C, again, and that's going to modify various proteins within the cell. So you can see the relationship between these two and how it's really different pathways, different effector molecules that these type of G proteins are utilizing. Our next signaling mechanism involves cyclic GMP and nitric oxide. Cyclic GMP is a second messenger in vascular smooth muscle that facilitates, and you want to highlight, dephosphorylation of myosin light chains, thereby preventing the interaction with actin and causing vasodilation. Now, the mechanism for nitric oxide signaling will be covered in detail, in more detail later on, but for now it's sufficient to note that it's dephosphorylation of myosin light chains, and as a result, you don't get the interaction with actin. Nitric oxide, of course, is synthesized in endothelial cells. Once formed, it diffuses into the smooth muscle, where it's going to activate guanylyl cyclase, increasing cyclic GMP in smooth muscle. And importantly, there's another protein kinase that's going to be activated here, and this is protein kinase G, which very nicely matches up with cyclic GMP or matches up with guanylyl cyclase. So we have three types of protein kinases that we've covered so far. Protein kinase A, that you matched up with adenylyl cyclase. You have protein kinase C, which you matched up with phospholipase C. And now we're seeing protein kinase G, which matches up with guanylyl cyclase. Of course, a lot of drugs and a variety of molecules in our body work through this type of nitric oxide cyclic GMP pathway, including various vasodilators. So the clinical correlate here, and it's shown in your margin, nitrates, which of course are in essence prodrugs of nitric oxide. Muscarinic agonists actually have an ability to bind to endothelial cells, increasing the production of nitric oxide through nitric oxide synthase. Bradykinin and histamine, both of which are endogenous molecules that work through their own receptor found on endothelial cells to also increase the formation of nitric oxide. So each of these molecules are vasodilators working through this type of pathway. Next, we have receptors that function as enzymes or transporters. And I'll summarize this section by saying there are a lot of targets here. These targets are going to be covered really throughout our notes. There's not really any specific that we're going to highlight right now, but you'll notice things like acetylcholinesterase, the angiotensin converting enzyme, aspartate protease for HIV. You'll notice and remember many of these enzymes that are targets for various drugs. And so stay tuned. These will be covered in much more detail later on. And then also drug action on transporter systems, including inhibitors of reuptake of several neurotransmitters. Of course, reuptake of neurotransmitters, one of the major ways, and most often the major way, for clearing neurotransmitters from the synapse. So reuptake inhibitors can affect things like dopamine or GABA or norepi or even serotonin. Next, we have receptors that function as transmembrane enzymes. These receptors mediate the first steps, for example, in insulin signaling, as well as many growth factors, including epidermal growth factor and platelet-derived growth factor. They're membrane-spanning macromolecules with recognition sites, for example, for the binding of insulin. And that's certainly a molecule that we're going to highlight here. The exam will want you to know how insulin signals. It's also true for many of these growth factors, but let's focus on insulin. It has a receptor with various components. It has an external binding site. It has a cytoplasmic domain, and that cytoplasmic domain is going to function as a tyrosine kinase, and really that is the major connection that you want to make here. Insulin signals by binding to an extracellular receptor, activating this cytoplasmic domain coupled directly to tyrosine kinase. Binding of the ligand then causes conformational changes such as dimerization so that the tyrosine kinase domains become activated, leading to phosphorylation of tissue-specific substrate proteins. Then guanylyl cyclase associated receptors, stimulating these receptors, for example for ANP, activates this guanylyl cyclase and increases cyclic GMP in a manner similar to what we've seen before. Finally, the last signaling mechanism we have are receptors for cytokines. Cytokines are things like erythropoietin, somatotropin, and interferons. These receptors are membrane spanning, and on activation are going to activate a distinctive set of cytoplasmic tyrosine kinases called JAKs, or Janus-activated kinases. Now, these Janus-activated kinases then phosphorylate signal transducers and activators of transcription, also known as STATs. So this pathway is summarized as the JAK-STAT pathway. The STATs are then going to dimerize, dissociate, cross the nuclear membrane, and modulate gene transcription. And what you might notice here is that the receptors for cytokines are actually very similar to making a hybrid of two different types of receptors. You'll notice that there's a tyrosine kinase component to this. The tyrosine kinase component should make you think of an insulin receptor. Then there's also a component of this that modulates gene transcription, which perhaps makes you think about things like steroids. So I actually think about cytokine receptors as really a merger of an insulin receptor and a steroid receptor. Because of the JAK-STAT components, JAKs being the tyrosine kinase, analogous to insulin receptors, STATs being analogous to the steroid receptor. We have a short section here, really a table on clinical trials related to drug development and testing. Of course, there are multiple phases of clinical trials, but prior to starting those phases, you undergo preclinical testing with a drug. The preclinical testing here involves 2 different animal species. And the purpose of those preclinical tests, just really safety and to test the biologic activity of the drug prior to trying this out in humans in actual clinical trials. Of course, the rule here is that we try to develop very good animal models for disease. And if you can develop a good animal model for disease, many times we are able to develop very effective drugs for those types of diseases. Of course, we still have a lot of work to do in that area. But once a drug goes into clinical trial, it goes through a series of phases, 1, 2, 3, and 4. In phase 1 clinical trials, a couple of things to notice here. First of all, it's a small number of people, usually around 50. These are healthy volunteers. Notice these are not people with the disease. And importantly, the question that you're trying to answer in phase 1 is the drug safe? It's important to point that out because I would imagine that most folks, the first thing you want to know about a drug in a clinical trial is, does the drug work? And that's not the question that we're going to answer in phase 1. Phase 1, we have to decide on a safe amount of the drug to take. So it's really safety and dosage that we're determining in phase 1 in healthy volunteers. And really, any healthy individual could potentially sign up for this phase of clinical trials. Now, phase 2. Phase 2 is the phase where patients with the disease are first treated with the drug most often. Now it's just a couple of hundred people that are involved. So a few more people are getting involved, and these are people with the disease. In phase 2, now is the time that we ask about the effectiveness of the drug. So in phase 2, the question is, does the drug work? Most often, it turns out, drugs that enter phase 2 trials, the answer to the question, does it work? The answer to that is no. Okay? Many times drugs are going to fail in phase 2 trials, most commonly. However, if the answer is yes, if the drug is effective, we can then move on into phase 3. Now, phase 3 is a much more extensive and therefore much more expensive undertaking. Notice that now we're dealing with a few thousand patients. Most often phase 3 is done in exactly the same setting as what the drug is going to be used in. For example, if it's in a hospital setting or if it's in an outpatient setting, that's almost always how a phase 3 trial is designed. And it's designed to test further the effectiveness of the drug as well as common side effects. So again, we get a lot of good information from phase 3 trials, really kind of honing what we know about the drug, preparing it now to go out onto the market. Once phase 3 is completed, the drug company then is going to apply for a new drug application with the FDA. Once that review is completed and the FDA approves the drug then goes out onto the market. And that's when we start phase 4, which is a post-marketing surveillance program, again, after FDA approval. Phase 4 is actually where physicians can most often get involved in clinical trials because essentially you become data collectors for this particular drug for several years after it's released. Certainly in phase 4, we get data on common side effects, much more than what we get from phase 3 because now many more people are taking the drug in phase 4. In fact, if the drug company is very fortunate, millions of people, in fact, will be taking this drug. So lots of potential for data in phase 4. But I also want to point out that in phase 4, you can discover some rare side effects of drugs. And a good story related to this is the story of the COX-2 inhibitors. You remember that when the COX-2 inhibitors first came out, they were very, very popular. The drug celecoxib, very, very popular. And of course, once that drug made it onto the market, after some years, it and its relatives like rofecoxib and valdecoxib, we discovered some cardiovascular events, heart attacks and strokes, leading to death in some of those cases. And that, of course, led to some of those drugs being pulled off the market. That was really discovered during the post-marketing surveillance part of their clinical trial. Finally, we have the teratogenicity categories. drugs in pregnancy. Remember that the categories here, A, B, C, D, and X. Of course, these categories are really based on safety in pregnancy. And of course, category A is considered the safest with no risk. Okay? Very few drugs fall into this category. For example, folic acid would be an example of something that fits into category A. Category B, while we may have had some data on animal studies that indicates a risk, we've not had any data really in humans indicating a risk. So category B drugs are considered pretty safe in pregnancy. Category C is really the unknown category because we may have some data from animals, but most often we have no data from humans, and therefore drugs that fit into category C fall into kind of the unknown category. We don't really know if they're safe or not. We don't have the data yet. Category D and category X have both been shown to be teratogenic. There is definite harm to the fetus from a category D or a category X drug. Importantly, though, the difference in terms of prescribing is that you might actually prescribe a category D drug. You would do that if the benefits outweigh the risk. And an example of that might be an anticonvulsant that the mother may be taking because it's the only anticonvulsant that works effectively on her type of seizure, and you may continue that drug despite its known teratogenic effects because of the benefit to the mother. However, category X, absolute contraindication. The woman becomes pregnant while on a category X drug, the rule is to immediately discontinue that drug and perhaps look for an alternative.